Good morning, everyone, and thank you for joining us on this sunny Saturday morning. We got an exciting series of lectures lined up for you. Along with me, I have my FIT Council co-chairs Deepak and Vikram, and we have the social media representative Anthony and Michael welcoming you to these lectures. This is our second series of lectures this year, and we're going to continue our focus on cardiac MRI. The first speaker, it's my pleasure to introduce our first speaker, Dr. Chaitan Chenoy. Dr. Chenoy is an associate professor of medicine at the University of Minnesota. He did his medical school from Gandhi Medical College in Hyderabad, India, residency from Guthrie Hospital in PA, fellowship from Tufts in Boston, and from Duke in Durham. Dr. Chenoy is an NIH-funded physician investigator. His clinical research efforts are focused on the clinical applications of CMR for patients with inflammatory heart conditions such as cardiac sarcoidosis, inherited heart conditions such as arrhythmogenic cardiomyopathy, cancer, and cardiovascular masses, including thrombi and tumors. Dr. Chenoy is also the director of the Advanced Cardiac Imaging Fellowship. Chaitan was my co-fellow when we trained together at Duke years and years ago. It's always a pleasure to see him. I'm sure a lot of you have seen him at multiple national and international presentations and heard about him. He recently came out with this huge paper about masses that he's going to, and he is going to be talking to us about cardiac masses. Thank you, Chaitan, for doing this.
Thank you, Mahi. Thank you. And it's good to see you. Thank you for the invitation. And thank you, everyone, for logging on this Saturday morning. So as Mahi said, I'll be talking about the role of cardiac magnetic resonance, or CMR, for the evaluation of cardiac masses. So just so we are all on the same page, what are the possibilities when we are seeing a patient with a cardiac mass? And we all think about the tumors or neoplasms, and obviously they can be benign or malignant. But the other possibilities are the thrombus, pseudomass, or the patient may have no mass, even if we are suspecting a cardiac mass. And what exactly is a pseudomass? So this is something that may be a normal structure that is mistaken for a cardiac mass on the initial imaging. And good examples would be Eustachian valve or crista terminalis that may be mistaken for a mass and referred for further imaging. Or it could be a variant of a normal structure, such as lipomatous hypertrophy of the interatrial septum or prominent epicardial fat, which can again be mistaken for a mass. Or the last possibility is it could be pathology, but it's not really a mass. And a good example of this is a hiatal hernia. So these are structures that are not truly masses, but there is something there, and hence we use the word pseudomass. So what is the importance of imaging? So why do we do imaging in these patients? So the main goals of imaging are to guide patient management. And these are the obvious managements that we try to do or we want to do. So if we see no mass or pseudomass, we typically do nothing. If we see a thrombus, we typically anticoagulate them. If we see a benign tumor, then we do surgery or sometimes conservative management, depending on what that tumor is. If it's a malignant tumor, then the treatment options include surgery, radiation therapy, chemotherapy, or rarely palliative care. And so we want to know which of these treatments to choose, and you can see the treatments are highly different or distinct, and therefore we want to know which of these categories the cardiac mass belongs to. And obviously we want to guide prognostication. We want to be able to tell the patient what to expect from the cardiac mass. And for all these purposes, I will argue in the next few minutes that CMR provides excellent diagnostic accuracy. It also provides excellent prognostic value. And I will show data that demonstrate that it is an independent predictor of long-term mortality in these patients. And I will make the case that CMR can be a one-stop shop for this indication. So this is the protocol that we would use or we would recommend to use And we have published this in a paper at the end of last year in the European Heart Journal. And the sequences that we typically would use for a cardiac mass protocol includes cine imaging, morphology imaging, which would be bright blood and haste, T1 and T2 weighted imaging, or these days we use mapping. And this is typically focused on the mass. Similarly, perfusion imaging, which is focused on the mass, and long TI imaging, which is a form of LGE imaging that I will talk more about. And finally, LGE, or late gadolinium enhancement imaging. And on the right is the algorithm for interpreting a case of suspected cardiac mass on CMR. And we simplified this into 4 steps to be able to get to the right diagnosis. And I will go over each of these steps in detail. So the first step to ask is there a mass? So as I mentioned, there is a good possibility that the patient may have no mass or may have a pseudomass. And the technique that really helps for this are the pre-contrast cine images, the SSFP cine images, because they provide very high resolution imaging, and we have unrestricted multiplanar imaging. So we are able to see practically everything to decide whether there is any mass or not. We may also use bright blood and dark blood morphology images. And here's just an example to show the resolution that CMR offers. And in this case, we can see there is something in the IVC that's coming down from the abdomen. And so this is most likely a tumor thrombus from hepatocellular carcinoma, or sometimes a renal cell carcinoma. So the other possibility when we decide there is no mass is, as I mentioned, a pseudomass, which can be a variant or a prominent normal structure. And if we decide there is a mass, then the next step obviously would be to think about a thrombus. So here are 3 examples of pseudomasses. So on the upper right, you can see crista terminalis eustachian valve. On the lower left, you can see prominent crista terminalis. And on the lower right, you can see lipomatous hypertrophy of the interatrial septum. So the next step, if we decide there is a mass, the next question to ask is it a thrombus? And for this, the technique that we rely on is called the long TI imaging, or long TI late gadolinium enhancement imaging. And this helps identify thrombus based on the unique fact that thrombi are avascular. So we are looking for masses with no contrast uptake. And this is an example of a left ventricular thrombus, which is very clear to see because that is the only structure that has no signal or is dark or black, with everything else appearing gray. So this is how we tweak the standard late gadolinium enhancement sequence. So this is not a special sequence. It's just a setting where we put the inversion time, or the TI, to be long, around 600 milliseconds. And we can get images which make the thrombi stand out. And so here on the left, you can see the regular late gadolinium enhancement imaging, where normal or healthy myocardium appears black. Myocardial infarction, here in this case, an apical scar, appears bright. Thrombus has an etched artifact. When we use a phase-sensitive inversion recovery, or PSIR image, the thrombus does appear black, but so does the normal myocardium. Whereas when we use this long TI with the inversion setting of 600 millisecond, everything except for avascular structures appear gray. So the normal myocardium is gray, the scar or MI is gray, and only the thrombus is black. And you can see it makes it much easier to identify avascular structures such as thrombus. Comparison to echocardiography. So this always comes up. So echo is obviously the standard and the most commonly used technique for the detection of thrombus. But we have data accumulated over the past decade to show that CMR is the most sensitive technique. And these are just an examples of a patient where the echocardiogram saw an left ventricular apical thrombus, which was also seen on a CMR. And these are the papers which came out of Duke over the past decade or so, which demonstrated the power of CMR for the detection of left ventricular thrombus. And the messages from these papers are on the right. So the first message is that we can reliably detect left ventricular thrombus, and we know this is left ventricular thrombus that we are seeing because this has been pathologically validated using patients that had cardiac surgery. And the next message is that CMR is very sensitive and far more sensitive than echocardiography. So we can detect many more left ventricular thrombi than echocardiography. And when we compare to echocardiography with contrast, obviously that is superior to echocardiography without contrast, but CMR is still far superior even compared to echocardiography with contrast. And this is a meta-analysis of 3 studies of STEMI patients, 430 patients who had both echocardiography and CMR. And in this meta-analysis, the sensitivity of echocardiography was 29%, so really poor. And specificity was very good at 98%. So this is an example of the performance of echocardiography. And the thrombi that are missed by echocardiography and detected by CMR are the ones that are smaller and mural, because as you can imagine, these are harder to detect. And what is the reason why CMR is so much superior compared to echocardiography? And the reason is not simply because of the resolution, it's not simply because of superior anatomic imaging. And I'll try to explain this concept here. So this is the same patient. On the left is a cine image, on the right is the long TI image. And you can see the cine image is a CMR image, which has all the high resolution and the superiority of the resolution provided by CMR. But even on this image, it is hard to distinguish the anterior mural thrombus compared to the left ventricular wall. But on the right, when we use this long TI late gadolinium enhancement sequence, you can see we can make the left ventricular thrombus stand out and makes it really easy to see. So in some ways, we are not simply using the superiority of the resolution or the anatomic imaging, but we are using tissue characterization. So we are not simply seeing things better, we are seeing things differently using CMR. And that is why CMR is so much superior compared to echocardiography. And here's an analogy that I use to explain this to my trainees. On the left is a low resolution image. On the right is a high resolution image. It's the same image, and you can see how the resolution makes you see whatever's in the picture better. But here's an image where we are using one of the tissue characteristics. So in this case, the warmth of the animals. And this is a special way of looking at it using thermal infrared imaging. And you can see the animals far better. So again, this is not simply using a higher resolution, but you're using and you're leveraging a unique tissue characteristic to be able to see the structures. And this is another example illustrating this. So on the left is cine image where you can't really make out if there is a thrombus or not. And on the right, you have a 2-chamber late gadolinium enhancement image and a short axis late gadolinium enhancement image. And what you can see is that there is a really small mural thrombus that is attached to this area of subendocardial scar in the anterior wall. This is a regular late gadolinium enhancement image. So back to the algorithm. So if we see a thrombus, then we have the answer for the mass, but what if we don't see a thrombus? So the next step, the next question to ask is this a tumor with highly specific characteristics? And so what do I mean by that? So there are certain tumors which have unique characteristics based on their location or based on their signal characteristics. And when we see those, we know the final diagnosis of what that tumor is. And examples of this include pericardial cyst. And so we see it outside the myocardium. It is in the pericardium or adjacent to the pericardium. It is well defined, does not take up any perfusion or contrast, and the CMR characteristics are consistent with fluid. Similarly, we can identify lipoma very easily because all the features are consistent with that of fat. We can identify fibroelastoma because of the unique location attached to the valve. It's often pedunculated and mobile. Similarly, myxomas, the typical ones at least, we can identify based on the location, the attachment to the interatrial septum, and it's typically avascular except for the stalk, which can enhance. And melanoma is another example, which uniquely has a very short T1, and therefore it appears bright on the T1 weighted sequences. And so when we see these unique features, we are able to get to the answer. And obviously, we know whether it's benign or malignant based on what the final answer is, the melanoma being malignant and the others being benign. So this is step 3. And then the last step is if it doesn't fit into any of these slam dunk diagnoses, then we look at the characteristics and we try to decide, is this a benign appearing mass or is this a malignant appearing mass, both being tumors? And the characteristics that are well known of benign tumors include well-defined borders. It does not really infiltrate the surrounding myocardium. It's relatively homogeneous uptake and homogeneous characteristics on T1, T2, and perfusion imaging, as opposed to malignant tumors, which often have ill-defined borders. They are highly infiltrative and invasive of the surrounding myocardium, and it can be heterogeneous in appearance and can take up contrast heterogeneously and often have areas of necrosis as seen on this bottom right image. And so that's the algorithm, and let's go over how accurate CMR is. And so I'll summarize the prior literature to put into perspective our paper. So the first paper of the accuracy of CMR diagnosis was published in 2011. They looked at 14 benign and 8 malignant tumors comparing to histology, and CMR had a 95% accuracy to distinguish benign from malignant. Berukum published a large pediatric paper looking at 78 masses in children, and again, CMR had 97% accuracy. Pazos Lopez published in 2014 looking at 17 benign tumors and 25 malignant tumors. CMR had 79% accuracy, which is lower than the prior papers. But some of the key features, such as tumor infiltration, were not really considered in this paper. And in 2019, the Brigham group published a paper with 25 benign tumors, 28 malignant tumors. They used 2 reviewers. One had an 89% accuracy and one had a 94% accuracy to distinguish between benign and malignant tumors. So the numbers for CMR are very high, but there are limitations to these papers. These are all relatively small numbers, as you saw. And the accuracy data is limited to benign versus malignant tumors. And these are largely also based on histology. But as I just explained, benign and malignant tumors proven by histology are only one small subset of all patients that we see with suspected cardiac masses. And for that reason, we decided to do a large study, a multi-center study of over 900 patients with suspected cardiac mass. And we included everyone, regardless of what they eventually were found to have on the CMR. So we included patients with all 5 categories: patients with no mass, pseudomass, a thrombus, a benign tumor, or a malignant tumor. And the clinical diagnosis from the CMR reports were compared to a reference standard of final diagnosis. And so how did we get to the final diagnosis? We made the final diagnosis using all available patient data. And so in this case, we used the histology data if it was available. It could be histology of the mass or even extracardiac histology. Sometimes we have data on extracardiac malignancies. We looked at the response to treatment. For example, did the patient respond to anticoagulation, which would confirm that the mass was indeed a thrombus? We looked at clinical outcomes. How did the patient do? Did the patient die soon after? In which case it is more confirmatory for a malignant mass, or did they do just fine, which would support for something non-malignant? And we finally looked at what diagnoses were made subsequent to the CMR. Did they come back and have other imaging which changed the diagnosis, or what was the true clinical final diagnosis? And we used all this information and we put together and we decided what the final diagnosis was for each of these patients. And we did have pathology data of the mass in about a quarter of patients. So 226 patients, we had histology data from the mass, but the remaining, we arrived at the final diagnosis using all other available information. And we compared the CMR diagnosis from the reports to this final diagnosis. And we found that the accuracy to identify the mass and classify it into one of these 5 categories was astonishingly high at 98.4%. So there were only 14 inaccuracies in this group of 903 patients from 4 different centers. And these are the 14 inaccuracies or discordances that we found. There was one case where the CMR did not see a mass, but something was seen on echocardiography, which proved to be a papillary fibroelastoma because the patient eventually did go to surgery and have it taken out. And there were 5 instances where we confused a myxoma for a thrombus or vice versa. So 3 instances where a thrombus was labeled as a myxoma and 2 instances where a myxoma was labeled as a thrombus. And this, we believe, happened because some of the early literature described myxoma as appearing heterogeneous, when in fact, a good proportion of the myxomas can appear avascular, similar to a thrombus, except for the location and the stalk, which can enhance. And there were only 2 cases where we missed the diagnosis of malignant tumor, and we classified them as benign tumor. So the next question we wanted to ask is, since we used the clinical reported diagnosis, is the accuracy influenced by the fact that the reporting physician had other information, for instance, information from the history about extracardiac malignancies and maybe information from other imaging? So we decided to look at how much CMR contributes to this in isolation. And we did blinded reads of a subset of these 900 patients. So we looked at 200 patients completely blinded to all clinical information. And we saw how accurate CMR was. And in this subset, we found the accuracy to be 94%. So clinical information obviously helps improve the accuracy, but it's only contributes slightly. The majority of the power of the CMR diagnosis does come from the CMR images. And many of these patients, and I will show you in a subsequent table, did have extracardiac malignancy. And among patients who have extracardiac malignancy, we found patients with no mass, pseudomass, thrombus, even benign tumors, and obviously malignant metastatic tumors. And this was a paper that was published soon after our paper came out, and this is from the Brigham, and they looked at 72 patients, again, those determined to be benign or malignant, and the sensitivity of CMR was 98% and specificity was 84%. So this is to show that ours is not the only paper which shows a really high sensitivity and diagnostic capability for CMR. It is confirmed in other papers as well. And the unique contribution of our paper, our study, was the prognostic value of CMR diagnosis. So we looked at up to 10 years of outcome. We looked at all-cause mortality. The median follow-up was 4.9 years. And we found that patients with no mass, pseudomass, or benign tumor on a CMR diagnosis have a similar mortality, and that's what you would expect to see. Thrombus had a higher mortality, but patients with malignant tumor really had a very high mortality. And this is what one would expect clinically, and this simply confirms that CMR diagnosis fits with what one would expect from these diagnoses. And the intermediate mortality of thrombus is more related to the underlying substrate. So patients who have thrombus, obviously, many of them have left ventricular dysfunction, coronary artery disease, cardiomyopathies, and other causes which can contribute to their mortality, even if it is not directly the thrombus. And we looked at the prognostic value in multivariable analysis after adjusting for age, cardiac risk factors, left ventricular ejection fraction, and even the presence of extracardiac malignancy. CMR diagnosis still had independent prognostic value. And finally, the prognostic value was the same or similar between patients with and without extracardiac malignancy. So the fact that someone had extracardiac malignancy did not contribute in a significant manner to the prognostic capability of CMR. And as I mentioned earlier, if you look at the group with extracardiac malignancy, which was 286 patients, we found all 5 categories of diagnosis in these patients. So we found 47 with no masses, 27 with the pseudomass, 32 with the thrombus, 23 with benign tumor, and 157 with malignant tumor. So this shows that CMR can overcome or provide information above and beyond the pre-test probability, because one would assume extracardiac malignancy, we would see a malignant tumor, but CMR shows that we can identify all the 4 or 5 categories of tumors. So a little bit about embolic outcomes. So what I presented so far was about all-cause mortality. How about the embolic outcomes of left ventricular thrombus detected by CMR? And this is important because, as I mentioned, we see a lot more left ventricular thrombi on CMR. So the questions that arise are these associated with embolic events? And the ones that we see on CMR that are missed on echocardiography, are they just as harmful as those detected by echocardiography? Or is CMR overdiagnosing this? Is it oversensitive? And are we picking up thrombi that have no clinical consequence? And these are logical questions to ask because, as I said, CMR picks up mural and small thrombi. And intuitively, these are not as worrisome because we know that larger and highly mobile and cavitary thrombi are the ones that are associated with embolism. And so we looked at this in a paper that we published a couple of years ago, where we looked at 155 patients with left ventricular thrombus, and we matched them to 400 patients with no thrombus. And we looked at their long-term outcomes up to 8 years with a median follow-up of 3.3 years. And we found an annualized rate of embolism. So this is stroke, PIA, or peripheral embolism, of 3.7% for left ventricular thrombus and 0.8% for matched patients without left ventricular thrombus. So this is about 4 times as higher. And this was significantly different. And interestingly, as you can see from this Kaplan-Meier curves, the risk was not only in the initial period, but it extended all the way to 8 years. So the risk never really went away, even though we assume the risk associated with the left ventricular thrombus is only for a few months until it resolves. And the second question, as I asked, is what about the ones that are missed on echocardiography and detected on CMR? Are they equally as bad? And we did not find a difference in the rate of embolism between those that were detected by echocardiography and those that were missed by echocardiography. In other words, those that are picked up on CMR and missed by echocardiography have the same or similar rate of embolism over 8 years. And therefore, we are not simply oversensitive or over-diagnosing this, but these are in fact left ventricular thrombi that have clinical implications and can lead to embolism. And in this study, the sensitivity of echocardiography was 48%, so 37% for non-contrast and 54% for contrast echocardiography. And this is similar to the bulk of the literature, where the sensitivity of echocardiography is around 50% compared to CMR as the reference standard. These are examples. On the top is a patient where left ventricular thrombus was detected on both CMR and echocardiography. The patient had a stroke after 2.5 years. The second, patient B, is someone where echocardiography with contrast did not see a left ventricular thrombus, but CMR did. And the patient had a stroke 5 days after CMR, which again proves my point that the ones that are seen on CMR are important and can have prognostic implications, and therefore should be treated the same as the ones that are detected on echocardiography. And on the last is a patient who had no thrombus on CMR and did not have embolic events at 5.8 years after CMR. So this is a follow-up paper that we did looking at left ventricular thrombus in non-ischemic cardiomyopathy. We did this because practically all the literature on left ventricular thrombus is in the setting of MI and in ischemic cardiomyopathy patients, but we do see thrombi in non-ischemic cardiomyopathy patients. And so we looked at 48 such patients, compared them to 124 patients with ischemic heart disease. We found that the embolism was not different, and the sensitivity of echocardiography was not different between ischemic and non-ischemic cardiomyopathies. So again, we should consider them as having the same risk and the imaging modalities to have a similar performance, regardless of whether it's a non-ischemic or an ischemic cardiomyopathy. So what are the caveats and nuances? So far I have talked about CMR as close to perfect, but obviously CMR is not perfect. And what are the instances where CMR may not be useful? So in cases of small or highly erratically mobile masses, and so examples would include vegetations or really small papillary fibroelastomas, the CMR may completely miss these masses or may not be able to see this mass. And this is nothing to do with the resolution, because CMR does have a high spatial resolution. It has to do with the way that most CMR imaging occurs, which is segmented imaging, where we are not imaging the heart live or in real time, but we are acquiring data from several heartbeats, 8 to 10 heartbeats, and we are integrating those data. And one of the requirements of such imaging is that the masses or the structures remain in the same position between cardiac cycles. So if it is moving highly erratically, then the integration of the data does not occur correctly, and we may entirely miss it. The other type of masses where CMR does not help is obviously if there is metallic devices, metallic prosthetic valves. So any masses in or around metallic structures will not be seen with CMR, or at least not reliably. And in some instances, and I would argue this is rare, second imaging test may provide complementary or superior information. An excellent example is in patients with neuroendocrine tumors, where a unique type of PET imaging, gallium-68 dotatate, may provide better imaging and may clinch the diagnosis, whereas CMR may only be able to tell us whether it appears benign or malignant. And as we discussed about tumors and masses broadly in terms of the categories, but we did not really get to the specific subtype. And the subtype can sometimes be difficult to ascertain using only CMR. However, the specific subtype is typically not necessary to guide clinical management. And sometimes the clinical information, such as a history of extracardiac malignancy, can help identify the subtype. So if we are seeing a malignant appearing tumor in someone with a known extracardiac malignancy that is metastatic, let's say metastatic colon cancer, and we see a malignant mass in the right ventricle, then we can safely say that it appears to be met from the colon cancer. But again, that is using the clinical information, but not exactly using the CMR data. This is a small paper that tried to distinguish the two most common forms of primary malignant cardiac tumors, so angiosarcoma and lymphoma. They found that angiosarcomas tend to happen in younger patients, and it tends to involve the right atrial wall and the atrial appendage, and it can have or often has areas of central necrosis, as opposed to lymphoma, which is more anterior and appears to involve the right AV groove, encases the right coronary artery as opposed to invading it, and it appears more solid. And so these are some clues which can help distinguish between angiosarcoma and lymphoma, but obviously we need tissue before we go on to treatment. And the prognosis of these two are highly different, lymphoma having a much better long-term prognosis than angiosarcoma. The final caveat, this often comes up, how about mapping over conventional T1, T2 weighted imaging? We have not found that mapping adds a whole lot of value over conventional T1 or T2 weighted imaging. And as you can see from the algorithm, we didn't really talk a lot about mapping. The bulk of the contribution of CMR comes from the long TI and LGE imaging and Cine imaging. And there is some contribution from T1, T2, and perfusion imaging. So a quick few cases. What is this mass? So you can see there is something in the left ventricle, and it appears mobile. But if you look, it appears avascular on this late gadolinium enhancement image. But if you look carefully, and it may not appear very well, it appears as if there is a stalk to this mass. And on this late gadolinium enhancement image, the stalk appears to be enhancing. And so this turned out to be a left ventricular myxoma. They can occur in the left ventricle. And here are two other cases of left atrial myxomas. And this is simply to illustrate that they can be avascular except for the stalk, which can enhance. And we should be cognizant of this and not diagnose this or call this as a thrombus. And this was the errors that led to some of the errors in our paper. These are two cases. One has a left ventricular apical mass and one has a right ventricular apical mass. They look similar except for the ventricle that they are in. You can see the late gadolinium enhancement imaging and long TI imaging show that they appear very different. And so you can see patient one, it is entirely avascular, and this fits with the left ventricular thrombus. Whereas on patient two, the mass at the right ventricular apex is bright and enhancing, and this is not a thrombus, and this is more consistent with a malignant invasive tumor. And in this case, it turned out to be a MET from colon cancer. This patient did have metastatic colon cancer. Again, two patients, similar appearing septal thickening, and you can see patient one, this is a post-contrast cine image. You can see there is thickening of the antroseptum. Patient two is pre-contrast cine imaging, again, appears very thick, but this is not like hypertrophic cardiomyopathy, because you can see the outline of something in the middle of the septum and you are thinking about mass. And this is the appearance on post-contrast or late gadolinium enhancement imaging. You can see this appears completely bright and it appears enhancing, whereas the mass on patient two, it's not quite enhancing. It appears to be necrotic for the most part. And so this was cardiac sarcoidosis, and this was not a true mass. This was pseudo-hypertrophy of cardiac sarcoidosis in patient one. And on the patient on the right, this was a malignant tumor, and this turned out to be lymphoma. So I would say in summary that CMR provides excellent diagnostic accuracy, helps identify the type of mass which can guide management. It provides excellent prognostic value. It provides independent predictive value for long-term mortality and embolic events in case of left ventricular thrombus. It should be a one-stop shop for this indication with rare exceptions, as I just mentioned. And often the question comes up about multimodality imaging, and can we use CMR with other imaging tests? What about CMR plus echocardiography? And echocardiography, as we all know, is the first imaging test that raises the suspicion. Most patients, 78% of the patients in our multi-center study had echocardiography first and were referred to CMR because the diagnosis was not made reliably on echocardiography. And therefore, while we see the mass, it often does not provide the final diagnosis. And the reasons for this, obviously, are the limited tissue characterization and limitations related to acoustic windows. How about PET? And so this is the same Brigham paper that I mentioned that was recently published, where they looked at patients who had both CMR and FDG PET, and they tried to see whether using both CMR and PET contributed to the sensitivity and specificity. And as you can see here in the third column from the bottom, combining CMR and PET led to a lower sensitivity, 85%, and specificity of 88%. And the characteristic with the highest sensitivity was, in fact, CMR in isolation. And so I would argue that there is no real role for PET routinely. Obviously, there may be selected cases where PET may be useful, but not routinely. And similarly for CT, it may have a role when CMR is not available or is contraindicated, which I would argue is rare these days, because we are able to give contrast to virtually every patient, including those with GFR less than 30, and we are able to scan patients with devices. So there are hardly any patients that cannot get a CMR these days. But if there are centers where CMR is not available and CT is available, then it may be useful. And again, I would argue it has limited value as the modality of choice for routine use. And philosophically or logically, I would say we have data showing that CMR has a diagnostic accuracy of 98.4% and excellent prognostic value. So do we really need yet another imaging test on top of CMR? What is the need? Because I would argue this is as good as it gets in clinical medicine. And one of the basic tenets of effective multimodality imaging is that we should choose the single best imaging technique for the indication, and we should choose it as the initial test. And the goal is to reduce layered testing and costs. And these costs may involve costs of the testing, multiple testing, and also the costs related to the downstream investigations based on all the layered testing. And therefore, from this perspective, I would argue that for patients with suspected cardiac masses, the choice should obviously be CMR. Thank you, and I'm open to questions.
Thank you so much, Dr. Chenoy. That was a fantastic talk going over an in-depth discussion about use of cardiac MRI in evaluation of cardiac masses. That was really wonderful. At this time, I will first of all go over questions and comments that we had in the chat box during your talk. So the first question I have is there a difference in the sensitivity and specificity to detect thrombus using early gadolinium enhancement, that is 3 to 5 minutes after gadolinium administration with long TI versus late gadolinium enhancement with long TI?
So I think early enhancement is simply a misnomer. And so there is simply long TI late gadolinium enhancement or late gadolinium enhancement, which is the conventional or the regular imaging. The early part is simply because we use the time before imaging for delayed enhancement. We use that time to obtain the long TI imaging. And so that's why it is popularly called as early enhancement, but the long TI imaging will work regardless of when it is done. So it can be done even after the late gadolinium enhancement. So there is no such thing as early enhancement when you're looking for thrombus or looking for any late gadolinium enhancement sequence-based things. Does that make sense?
Yes, yeah, that I think that makes it quite clear. Thank you so much for that. Our next question here is, are there any technical errors that can lead to a false positive for a thrombus on cardiac MRI?
Technical errors. I cannot really think of what technical errors would be. I would say no.
Sure.
We haven't, yeah, I mean, we have published quite a few papers on this, and I can't imagine what the technical errors would be. Obviously, MR can have lots of artifacts, and those are very obvious. And there are ways to minimize and avoid artifacts, but there isn't any instance where we would misdiagnose an artifact as a thrombus.
Got it. So I have another comment here. It says, our institution mass protocol also includes a 3D Vibe sequence, pre and post contrast, which is improved spatial resolution by about 2 millimeter. Would like to know your thoughts about that sequence in the evaluation of cardiac masses.
Yeah, we don't use that. And I know the protocols vary from center to center, and there are many different things that different centers do. I don't really have an opinion about this specific sequence per se, because I don't have much experience with it. But I would argue that the protocol that we used, which did not include any 3D wide sequence, had excellent prognostic and diagnostic accuracy. So we don't really need anything else than the standard sequences that I mentioned that we used in our study.
Beg your pardon. Thank you so much for that comment. So another question that we have here, is there a role for transesophageal echocardiogram in evaluating cardiac masses, since CMR is more available now?
I believe the question is about left atrial appendage thrombus, maybe, because that's where we routinely use a TEE. And there are limited studies showing that CMR is just as good as a TEE for the detection of left atrial appendage thrombus. And there are centers which use it, including ours, not routinely in place of TEEs, but in cases of patients who may be high risk and may not be able to tolerate TEE. It's a good question whether we should do CMR in all of these, but obviously there are limitations related to the availability and the resources. It's much easier to do a TEE at every center than a CMR. But the limited data show that CMR is just as good. And we have done quite a few of these patients where we have excluded left atrial appendage thrombus using CMR, and they have proceeded to ablations and cardioversions, and we have not had a single issue.
I think also your thoughts on TE just for evaluation of masses in general, Chaitan.
Oh, yeah. So I'm not sure about if you have CMR, whether TE would have any role, especially after a transthoracic echocardiogram. So as I mentioned, the best test here is CMR. And if you have it available, then you should go straight to a CMR and not subject the patient to, arguably invasive TEE.
Great point. Our next comment here is, can cardiac CT also be used to differentiate thrombus from vascular masses in its, I guess, maybe it means in people whom cardiac MRI cannot be done.
Yeah, so there are really small papers showing the role of cardiac CT to detect left ventricular thrombus. The data are much smaller and limited compared to the CMR data. And that limited couple of papers show that CT works very well. They have not compared that to echocardiography. There's no data comparing cardiac CT versus echo. There's no data comparing cardiac CT to CMR. So the limited few papers say that cardiac CT works well for the detection of left ventricular thrombus.
Great, thank you so much. Dr. Ashworth, do you have any questions or comments to that?
No, I think I guess we got a few more questions, but thank you very much, Chaitan. I think Vikram can continue with the questions. I think you really brought out the value of, the tissue characterization with MRI, and you showed how it can help with evaluation of masses. So thank you very much, Chaitan. I had a couple of questions. One is, for T2-weighted imaging, we usually use, the T2-weighted turbospin echo sequence with and without fat sat. What is a good sequence that you would recommend using for T1-weighted imaging?
So we are now transitioned to T1 mapping for our mass protocol, because that's part of our standard core protocol that we use in all these patients. But again, when we looked at the individual sequences and how much each of these contributed to the final diagnosis, we did not go into that depth in the paper, but we did not really find a whole lot of contribution from either the T1 or the T2 weighted imaging. because in many cases, as some of the literature says, it may be isointense or slightly hypointense or hyperintense. Right. So unless it is a very obvious, unique case such as fat, where you can clearly identify on the T1 weighted images, or melanoma, where you can identify it on the T1 weighted images. But short of this, for most masses, the T1 and T2 don't really help distinguish between what type of tumor it might be. So we did not really find a whole lot of use from those sequences, even though we do continue to include them and do them.
Awesome. Thank you. The second question I had is, you showed data about thrombus and how the risk of stroke persists for like years and years outwards. And, as currently we use anticoagulation for a very limited time in these patients. Yeah. For too long. So do you think we should relook at those guidelines about how long we anticoagulate?
Absolutely, I think so. And so we are working on a paper looking at serial MRIs in some of these patients who had serial MRIs. And we are trying to see how long the left ventricular thrombus persists. And this is still work in progress that we haven't published yet, but we were amazed to see that at 3 months, only about a quarter of the thrombi resolve. And so we see about 3/4 of the thrombi still persisting at 3 months. And then at 6 months, we see 50% of the left ventricular thrombus persisting. And over at 12 months, we see 1/3 of the left ventricular thrombus still persisting on serial MRI imaging. Obviously, these are patients who were referred clinically, and so it's a biased subgroup, but still, I believe that left ventricular thrombus persists for much longer than we believe. And even if it resolves, it may recur, and therefore the embolic risk is not something that's short-term. And I think if we have the data in the future, we might realize that these patients need to be anticoagulated indefinitely. The 3.7% risk, that was annualized risk over 8 years. And so that's higher than the CHA2DS2-VASc score of 2, because the risk with CHA2DS2-VASc score of 2 is 2.9%. And we anticoagulate people with CHA2DS2-VASc score of 2 indefinitely. And this risk is actually even higher than that. So it's almost like CHA2DS2-VASc of 3. And I'm beginning to think that folks that have left ventricular thrombus, at least from an irreversible or permanent injury, for instance, from an MI, where the scar is not going to go away, in those cases, perhaps we need to anticoagulate them indefinitely. Obviously, there are those cases where the LV improves and the risk changes over time. Folks that don't have a whole lot of scar or may have a left ventricular thrombus in the setting of stress cardiomyopathy or eosinophilic myocarditis, where things change and improve drastically. Obviously, in those cases, they may not need indefinite anticoagulation, but for most patients with ischemic cardiomyopathy and large apical scars, I'm beginning to think that we need to anticoagulate them for much longer.
I agree. I think that sounds entirely reasonable. I think we have a few more questions. Vikram, you want to take over?
All right, sure. So there are a few questions kind of bunched together on the same theme. This is related to the utility of cardiac MRI in STEMI patients. Do you suggest it be done in all STEMI patients, or are there any high-risk features on MRI that would suggest a high risk of thrombus in these patients?
That's an excellent question. So for the indication of looking at LV thrombus. So contemporary data suggests that in this current era where we do primary PCI within 90 minutes or so in most people, the risk of left ventricular thrombus is around 7%. So these are large studies looking at consecutive STEMI patients who had CMR. And so it's not a small risk. And as I mentioned, echo probably detects only about a third or a half of those. And so it's not an insignificant number. And there are papers that have identified the subset of people who are at higher risk, and these are patients with large LAD MIs. And so virtually all, so anywhere from 95 to 100% of the thrombi in these papers occurred in LAD MIs that involved the apex. So these are large apical MIs. And so not every patient needs to have MRI, but perhaps those with significant left ventricular apical wall motion abnormalities on echocardiography may be the ones that would benefit from CMR before they are discharged.
Excellent points there. Thank you so much for sharing that. I guess the next one is more of a comment, but with the current iodine-based contrast shortage, is your institution starting to shift to CMR for left atrial appendage thrombus in patients who cannot get TEE?
Yeah, I'm not sure how the iodine-based shortage affects TEEs, but we do do CMR for this purpose in folks who are deemed to be at high risk for TEEs. For instance, those that have had prior lung transplant or other cardiothoracic surgeries, they are at a higher risk for esophageal perforation, and therefore we send those folks for CMR as opposed to a TEE. And again, there may be the subset of people who cannot tolerate TEE or may be too sick to have sedation or propofol for a TEE, and those folks we use CMR to look at left atrial appendage thrombus, but we don't do it in every case, again, because we simply don't have the capability to accommodate every patient who needs left atrial appendage thrombus rule out.
Excellent point there. Next question is, what is the role of CMR over TEE for detection of small mass attached to valves like fibroelastoma, vegetation, or blob of calcium? So I guess, it can probably be extrapolated like role of CMR in assessment of masses attached to valves which are small.
Yeah, so yes, again, this is the Achilles heel of CMR. So if they're really small and they are highly mobile, masses attached to valves may not be erratic or independently mobile. They may move in a consistent manner between the cardiac cycles, and we may be able to see them. But I would argue that vegetations, I would not use CMR to investigate whether someone has a vegetation or not. Clearly, TEE is the imaging modality of choice for that reason. Similarly, calcium, it may be hard to distinguish whether the calcium is part of the valve or is it an independent mass, especially if it is small and attached to the valve. So it all depends on what exactly the mass is. And so when our referring physicians come ask us, we look at the echo, and if TEE is available, we look at those images and we make the decision on a case-by-case basis whether CMR might offer any additional information and whether we will be able to characterize the tissue. And as I said, it all depends on the size and how it is moving between cardiac cycles and within the cardiac cycle.
Excellent. I think this was an excellent discussion, and wish we could continue answering some of the other questions and comments, but I think in the interest of time, we are probably going to stop here. Thank you so much, Dr. Chenoy, for again making time for this talk this morning and for the excellent presentation and discussion. For folks who are listening or seeing this presentation, Dr. Chenoy has kindly shared his email, so please feel free to send any questions to him. And I would hand over to Dr. Ashworth to introduce our next speaker. But Dr. Chenoy, thank you so much once again.
Thank you for having me.
It's a
Thank you very much. Thank you very much, Chaitan. That was a very comprehensive review. As most of the users know, cardiac masses is one of the tricky things that we evaluate in CMR, and you really simplified it and showed the advantages of cardiac MRI. And it's,
Yes.
I agree completely, the gold standard and the test of choice for patients with cardiac masses. So thank you again very much for spending your Saturday morning with us.
Yes, thank you for having me. And as Vikram mentioned, please feel free to email me about cardiac masses or practically anything to do with CMR. Thank you.
Awesome. Thank you very much. I will move on to introduce our next speaker, Dr. Ravi Ashworth. He is the professor of pediatrics and radiology at the University of Iowa. He did his MD in India and then residency in Valhalla, New York at the Maria Freire Children's Hospital. He did his fellowship in pediatric cardiology at Rainbow Babies and Children's, where he also served as the chief fellow, and he did his cardiac imaging training at Boston Children's and Brigham. He worked as an assistant professor at the Case Western Reserve University and an associate professor there, while he was also the program director for their fellowship program and the director for the cardiac MRI program. He's currently at the University of Iowa, where he directs the non-invasive lab and cardiac MRI, and also their pediatric cardiology fellowship. He's been active in education and teaching and mentorship. And it's my honor to introduce him. He also happens to be my husband. So I'll pass it on to Ravi.
Hopefully everybody can see the screen and hear me.
Yes.
See you, Dr. Ashworth. Thank you.
Perfect. Thank you very much for the ACC leadership and all the people working in the background and foreground to make this possible. This seems to be taking off very good, and I think it's very helpful for the trainees and folks likewise. So this part of the discussion was, since it is based on the theme of imaging, advanced imaging in particular, to talk about what can advanced imaging help in congenital heart disease. So let's see. Okay, no financial disclosures. So the outline I thought about doing this is advanced imaging in congenital heart disease is first thing is, as adult cardiologists, which are most of the audience here, is how can it help, advanced imaging. It could be sometimes TEE, it could be CT, it could be MR, or it could be more than that, which I'm going to share a few slides in the end. In a few arenas, one is when you see a congenital heart disease that is either repaired or if it's not repaired and you want to figure out a few things. We all know that echo is probably going to be not that great once the patients start becoming older in terms of images, especially complex imaging. So how can MRI and CT help? We, I think at this point, agree that CT and MR is very good both for spatial resolution and also for other things like flows, tissue characterizations, and things like that. But how do we apply it? And especially when we don't do this every day, what are the things that we should know when we see what seems to be zebras in our everyday practice for you guys is, okay, so this is what we see, how do we utilize MRI and CT? So the way I'm going to do this is, I'm going to go over a few specific cardiac lesions, simple ones, because the concept is going to be the same once you get to know what exactly you're looking at. And the specific cardiac lesions would be AST, VSD, atrioventricular septal defect, PDA, which is patent ductus arteriosus in our terminology, coarctation of aorta, and I will just show you a few miscellaneous cases. So of course, congenital heart disease, in a lot of things in these slides, I'm not going to read a lot because it's all recorded and people can view it. The incidence is about 40,000 births per year. And one thing to note is the population of adult congenital heart disease patients is growing at a rate of 5% per year. And at any time now, the patients with adult congenital heart disease is actually more than the number of kids with congenital heart disease at this point. So now acyanotic congenital heart disease, we can divide this into lesions that cause increased pulmonary blood flow. That means it has to have a left to right shunts that include the lesions that we just discussed, with also one of the things that commonly seen, especially with advanced imaging, is a partial anomalous pulmonary venous return. And with normal blood flow, you could have coarctation of aorta, Epstein's anomaly, and other obstructive lesions and miscellaneous lesions. And when I talk about normal blood flow, I'm talking about normal pulmonary blood flow. So some of the imaging sequences that we commonly use and how do we utilize them in congenital heart disease cyanotic. So, Dr. Chenoy went over some of the sequences, and in the previous lectures and the lectures to come, there's going to be a lot of terminology used in congenital heart disease. Some of the things you want to just look at anatomy and figure out a few things. Black blood anatomy, which are still images where the blood pool appears black, is one of the good things to do. Black blood imaging is also good, especially when there are artifacts from previous things like coil placements, stent placements, and device placements. So it is more forgiving than the regular steady state free precision, which is the SSFP imaging. So that's for anatomy. You could use black blood. Next, SSFP, which is the cine images that we obtain. So this is a stack of short axis images that we obtain in the ventricles, and this is the 4-chamber views that we obtain. So by doing this, first few things we can do is, one of the most important things I want to tell you guys is, if you have a heart disease that is very complex and there's not much one can make out, getting a straight axial cine images from the diaphragm all the way up to the neck probably can sort out most of the orientations, most of the lesions, and people don't have to think much when they're doing MRI scans, figuring out what are all the kinds of angles, all that stuff. Number two is you get an MRA, probably we choose to do in the coronal plane, so you can include all the way up to the branch pulmonary arteries and back and front from the descending aorta all the way up to the right ventricle. Between these two scans, I think we can figure out what the anatomy is, and then later on I will tell about how to figure out some of the flows. So if anybody is stuck at any point, straight axial cines and an MRA probably will help sort out most of the things. So here, now you do a cine SSFP. What are the things that we get from here is, obviously we can contour these in the diastole and systole, and we can get volumes, and then you can index it to body surface area if need be, and then you can also get ejection fraction and also, as I said, anatomy. So those are the most important things here, and most of our reporting will be based on this sequence. Some of the times, again, I think the SSFP sequence might itself have problems when there are two things. One is artifacts, which could be from metal, and also flow turbulence. For example, if it's a bicuspid aortic valve with a velocity closer to, let's say, 3 meters, 4 meters per second in the echocardiogram, when you do cine, which is SSFP type, then there might be a lot of flow artifacts and you might not be able to see things. You can switch to what is called as a flash sequence or a GRE sequence, and that will help get the images a lot better, like this in this patient with a bicuspid aortic valve. So this is just reiterating how we use the short axis to contour and get your EF and volumes. So one thing is clear now. We can get images, we can get a little bit of anatomy, and then we can also get volumes. Next is most of our work depends on flow. So you can get flow, and the flow can happen in two planes. One is through plane, which is getting the flow with the area of interest of the blood vessel, making it look like a circle. So that is aorta here. We got this aorta here, and also arranging the views in such a way that the main pulmonary artery turns out to become a circle by doing double oblique methods and setting up the planes, which one will know once somebody is starting to do MRI. So very important is to flow through the aorta and flow through the pulmonary artery, and it has to be through plane for measurements. So next is we also do flows to the mitral valve and the tricuspid valve. You can either do it separately if you can get the valves correctly en face, or you can do it in the same plane. But generally we try to do it in two different things, because sometimes the tricuspid valve opening correctly like this and the mitral valve cannot happen in one cut. So this is for the tricuspid valve that we have this here. So this one you can see what is the inflow, and it is also through plane again. By doing this, we get the amount of blood coming into the tricuspid valve into the right ventricle if we are focusing on tricuspid valve flow, and mitral valve flow is going to be blood flow coming from LA into the LV, and we generally do it below the valve, not above the valve. So next is sometimes gradients can be obtained a little bit better in a plane called in plane. So that is, if you want to get the aorta here, so if there is an area of coarctation here, then you get it in plane. So it is in the plane and not through the plane, like how we had decided before to get through plane here for aorta, and this is in plane. Some of the times the gradients that we get through in plane would be a little bit more accurate. However, with the caveat that the gradients by cardiac MRI are not that accurate as of echocardiogram. However, the flow data in terms of the volume data and the regurgitation fraction data is gold standard, and it's very, very helpful if done right. And when we do this, there is a term that sometimes people notice that the flow was not right because of the dephasing. What it means is, just like in the echo, similar to the Nyquist limit that we talk about, where if you exceed the Nyquist limit, then the graph will go to the other side, and that will not be accurate. Same thing here is when the protons dephase here, you can see that there is a lot of little black and white here. That means the velocity that we picked to encode in the direction that we want the flow is probably lower, and hence it dephases. So you might want to pick a encoding velocity that is a little bit higher, closer to where the real value is. You don't want to pick too high, or you don't want to pick too low, and you have to pick a little bit accurate. So for people in the cardiology section, which most of these are here in the group, looking at an echo report before, you can set your vanc closer to what the echo showed in terms of the number, rather than going from 100, 150 like most of the institutions start and keep on doing several slices. So flow wise, you can get through plane and in plane to get the volume data and also the gradients. And when we do the flow, you get the flow and the velocity data. For that, as we go through the lesions, you will see that all these things help with forward flow through that vessel. What's the backward flow? Knowing these two, you could calculate the regurgitation fraction. You can also get the peak velocity and the mean velocity, and knowing this, you could calculate the peak gradient by knowing the peak velocity, and the equation uses just the same simplified Bernoulli's equation. And the mitral regurgitation, calculated in one way or the other, where you can get flow in the mitral inflow, amount of blood that goes into the mitral valve into the left ventricle, and then you can also get flow of what blood goes out into the aorta. And obviously, if there is a mitral regurgitation, you know that the inflow into the mitral valve is going to be higher, because it also adds the regurgitant volume, and what goes out into the aorta will be the usual QS. So using those two numbers, you could get the regurgitation fraction of the mitral valve. In some cases, even though it is not the most accurate, depending on how much of the contouring nuances and how accurate one is in contouring, you could still use LV stroke volume, because when the LV squeezes, the stroke volume goes through the aorta, and if it is mitral regurgitation, goes through the mitral valve. So you can use that and compare with an RV stroke volume, making sure that there's no tricuspid regurgitation or pulmonary regurgitation. So once you get the data in terms of the volume and the flows, then you can do your math equations, how you did it in your high school, and start calculating every form of regurgitation, collateral flows, all that kind of stuff very easily. Then we used GAD enhanced MRA for anatomy, and that can be done, just a picture like this. And we have also done a study here, which most of the places do, to show that 3D SSFP is one of the sequence that we do, where we navigate and hold the diaphragm at a certain place when we scan and get images, which is ECG triggered, and then get images without gadolinium, and the images look spectacular, and we can do diagnosis of the anatomy. So we don't always have to use GAD for anatomy to do an MRA. So knowing those, now we can see how we can go through these lesions and figure these things out. Atrial septal defects, I'm not going to go through a lot of stuff here. We all need to know there are types of atrial septal defects, out of which the ostium secundum atrial septal defect is the commonest type here, and then there's the other types, which is the primum defect, and then the superior on the inferior sinus venosus, coronary sinus AST, very rare, very difficult to diagnose. And of course, you can use cardiac MRI, you can use cardiac CT, and also cardiac cath, and we will see how we can do that. So an example here, a 50-year-old with a heart murmur. Important thing is wheelchair bound. So in first of the examinations, 6 months before we had done an MRI, an examination had showed this kind, and then 2 months later was in for an upper respiratory tract infection in the quick care visit, and here this was noted, grade 3 or 6 systolic vibratory crescendo murmur and gait abnormality. So a chest x-ray was done, and the chest x-ray reads said there is some prominence of central pulmonary arteries and there is a concern for shunt vascularity. And echocardiogram was done. Images are poor. You saw the bony structures and the scoliosis kind of stuff, so it's not that easy. No obvious interatrial shunt was visualized. A bubble study need to be considered, and then in the bubble study, clearly in all the echo images, it was said it was limiting because of the challenges that they had to face technically, but an RV was enlarged. So usually this is what I see for the most adult congenitals coming to us for scans, is the RV is enlarged and we do not have a real answer, and we are not able to see the atrial septum very well. And here is the SSFP imaging showing this is the left atrium, this is the right atrium, and the IVC. You almost don't see a whole lot of an atrial septum here, and then the pulmonary artery is dilated. So short axis view of the ASD, you see that there is a big atrial septal defect here. And we do an MRA in all the patients who have an ASD or a right-sided dilatation to make sure that the pulmonary veins are not abnormal, and the pulmonary veins were normal here, and the dilated PAs secondary to the flow that was going through the AST into the right ventricle, into the PA, all 50 years of his life. So then we got the volumes, as I said. So now we got the images, we got the volumes. The right side was dilated, and then we got the flow. We got the flow in the aorta. We got, that's called the QS. Then we got the flow in the pulmonary artery. As you see, it's dilated, and then you got aorta 30 mLs coming out, and the pulmonary artery at the same time 95 mLs coming out. So obviously there's a lot of blood going into the pulmonary artery compared to the aorta. So now this is how you get your QS measurements. We all now learned how to do a flow across the aorta, so we got that, which is the through blue, and then MPA. So the QS is just a number that you calculate this way, the amount of flow going, and you get a QP to QS of 3.1, and we all know that the normal QP QS is 1, because whatever comes to the right side of the heart makes it to the left side of the heart, and so hence blood flow through every valve should be the same. Here it's 3 times more into the pulmonary circuit. So no evidence of increased PA pressures. The right atrium and the right ventricle dilated. We got that by the volume data. QP to QS more than 3. We got that by flow data. And then we also used the morphology scans to see if there was rims that were adequate to put in a device, and the rims were inadequate. And then we also want to make sure that the pulmonary venous return was normal, so that we got by an MRA. So here we got the data of all the things that we need to send him to where he wants, or where he needs to go, is a surgical patch closure of the AST, and he's doing well now. So the management of ASD for the board questions generally asked, even though that's not something we just depend on, which is a QP/QS number that's quoted everywhere of more than 1.5, but we have some patients who are 1.5 but have no right ventricular dilatation. There is no other issues, so we necessarily don't just go by one number. And then adequate septal rims, if there are, then we can send them to the cath lab for a device closure with a device like that, and if it's not, then you send them to the surgical closure. So obviously when we talk about advanced imaging, it is also important that echo plays an important role, and you see the AST with left to right flow. It's important to see left to right flow in adult patients, especially because if it is bidirectional or if it is right to left flow, you want to make sure that their pulmonary vascular resistance is not high, that it will prevent closure, because your cardiac output might be dependent on the right to left flow. And the MRI can help you showing the margins of the AST. Very, very thin septum, sometimes might be an issue in MRI. TE is very, very nice for that, but you can get almost all data. So then you put a device here into the second MAST, as you see that device right there. And you can also use cath, balloon size it, and then you do the device, and you put the device into the AST here, and you can then release it, and then you can get an angio after deployment to make sure that there is no more shunt. So a few words about ostium primordial septal defect. One needs to know that patients mostly have trisomy 21 because this is associated with AV canal, and that's the AVST. And next is the sinus venosus type AST. Primary AST is to see in the adult population without repair and just showing up is very rare. However, sinus venosus ASTs do show up just like the second ASTs, and it's important to know this because the management is going to differ very much at this juncture here. So basically here, when the SVC comes, the SVC enters into the right atrium, and the atrial septum should divide that in SVC from the right atrium, the pulmonary vein that just goes behind in the left atrium. So there's a lot of things happening at this area, where if there is a hole right there, you end up having the right upper pulmonary vein being anomalous and draining into the right atrium. At the same time, you will have a hole high up where it's not amenable to cath, even though at this point one can argue about some of the procedures that are done. Even sinus venosus AST can be done. It used to be a no-no before, but there are some particular cases you can choose and do it. Same thing in the other side is the inferior sinus venosus AST, where the IVC comes here, and IVC has to enter the right atrium, separating this one atrial septum to the left atrium. So if there is a hole there, then that is inferior sinus venosus AST. So very easy to diagnose in an MRI after you get these views here. So usually if somebody is suspecting an ASD, I would recommend that people use what's called as a bicaval view, that is putting a point in the SVC and then an IVC and then getting some slices in the sagittal, mostly sagittal view, where it helps you to do the SVC coming here, and you can see that this is the left atrium right atrium, and you can see that the hole is right at the junction here, where almost like the SVC straddles the right atrium and the left atrium here. So that's a big defect that is here, that is superior, and it is all the way to the top where it straddles, and hence it's called the superior sinus venosus ASD, and the bicaval view is very helpful. And you can put color here. Some of the times you can also get the softwares to put color to show the directionality of the blood flow, and also you can see how it straddles. So some of the times this coloring is just like the echo in terms of as you see here, the red indicates the direction of which way to go, blue indicates and you know which way blood should flow. So encoding this way is just a little helpful for the eye, even though it's not of any importance in calculations. On the same token, inferior sinus venosus ASD, as you see here, the IVC is coming here, and then this is the left atrium and the right atrium, and you see that there is a bottom here that's not there, which is very well demonstrated here. Just an enlarged picture of this here, so you can see that here. So the only difference one has to make here is to make sure that it is not a secundum ASD, which is very low lying, but then there will be some rim at the junction of the IVC and the atrium will be here. But if you don't see any rim and you almost see like the IVC straddles the atria, then it is an inferior sinus venosus ASD. It is also important because here you would be thinking of a right lower pulmonary vein that could be abnormal sometimes. So the guidelines, I will put it up here for a few seconds for recording when people can see. Every one of these, ASD, VSDs, coarctation, PDA, will have guidelines, AHA, ACC guidelines about, when you see a secondum ASD, you thought about it by clinical examination and suspected something in the echo, and then you got an MRI/CT, depending on what you wanted for which case, and you sort it out, then this guidelines will help figure out what is the shunt, what is the pulmonary artery pressure, and what is the functional limitations. And using those three things that you can get from your CT and your clinical examination, you can send patients to either surgical or device closure, or you can not do anything and consult ACHD and pulmonary hypertension experts to see if something can be modified and then get back to one of the treatments, or the pulmonary hypertension is so bad that they have gotten to the so-called Eisenmenger stage that you might not be able to treat them with device or closure, and you might want to do treatments with medications to help the pulmonary hypertension at this stage. So what's the advanced imaging checklist for ASD at this point is either when you do by TEE, CT, MRI, you want to define the defect, what's the size of the defect, and what kind is it? Is it a secondum ASD, primum ASD, and is the margin suitable for placement of a device? Is there right atrial dilatation, and what's the volumetric assessment for RV dilatation, function of RV, QPQS, and any findings suggestive of pulmonary hypertension? Of course, we can get almost all of this by advanced imaging. Next, ventricular septal defects. So the theme, probably by this time you guys have gotten this, is it's all about getting volumes, morphology, flow, make a decision. So ventricular septal defects is a common isolated congenital heart defect, and it's the most one. Obviously, in terms of what is the most common congenital cardiac defect, now people can say it's bicuspid aortic valve, but different than a hole in the heart. VSD would be the second one if that's the only way you want to talk about congenital heart disease. Questions can go both ways. Some of the answers might not have VSD, bicuspid aortic valve, and if they have both, I would pick bicuspid aortic valve at this point. And most common cyanotic heart disease associated with VSD, Tetralogy of Flow. And the types of VSD, here it is: perimembranous, muscular, inlet, and supracrystal, commonest of which will be the perimembranous VSD. And the inlet type, whenever you hear it, you always think of AV canal and Down syndrome. And going again to show where exactly they are in the heart specimen here, these are the days when we did the dissection and stuff, and in the end of my talk I will show you that we can achieve all these things in virtual reality and in 3D printing. So perimembranous VSD, when you get the parasternal long axis just below the aorta, because it's subaortic VSD, and when you get the short axis view, the way to think about this as a clock face is tricuspid valve is around 9 o'clock, and the pulmonary valve is about right there, between 2 and 3 o'clock. So anything between 9 and 11 o'clock here, if you see a hole here, that's a perimembranous VSD. If you see just below this pulmonary valve here, it's a supracrystal VSD. That is the two things. Inlet VSD you would probably not see in this, you would see it in the 4-chamber view. So if you have a short axis view and you know the clock face, then you know what's a perimembranous VSD, supracrystal VSD, and then of course the muscular VSD is anywhere going in the septum here, somewhere in the septum, in the muscular part of the septum. And when you do a 4-chamber view, which I will show you later, you will see what's an inlet VSD. So it's not very difficult to conceptualize these things. Muscular VSD, just an example on how to plan and get things. So muscular VSD is anywhere in the ventricular septum here in the muscular part of it, and usually they are common right around what we have as the moderator band in the right ventricle, so right there. And then the inlet VSD is what we call this, and the way to remember always is when you do a 4-chamber view and you can see your tricuspid valve and mitral valve, and that's your inlet, and then there is a VSD right there, and hence it's an inlet VSD. When you cannot see the VSD here, and you only see when you tip it all the way towards the aorta, that's an outlet VSD of the subaortic type, and then you can decide how to design. So the clinical features are all based on the left to right shunt, volume overload, and over a period of time, if nobody treats it, then they get into the pulmonary hypertension by increasing vascular resistance, which can still be reversed, and if you still don't treat it, then they get irreversible Eisenmengers. And of course, you can use this as your imaging, and then I have just put up here to show what all the things that we can achieve here. So muscular VSD, can be anywhere, and it's an incidental finding. Sometimes I see in the groups which are interested in cardiac MRI saying, and then they post pictures like this and showing what is this an aneurysm, is this. If a patient had an VSD, the muscular VSD, and it probably got walled off for the most part. So that's the VSD, that was apical muscular VSD. And a board question for adult cardiology folks is from left ventricle to the right atrium, if there is a shunt not going to the tricuspid valve, going to here, it's called a Gerbode defect, and you can get these images. Obviously it has to be a flow right above the tricuspid valve from LV to RA. So once you have a VSD, you can use the same theme that I have used before, is to get volumes, to get flows, and then calculate the volumes and then go from there. So this again is talking about what is a hemodynamically significant ventricular shunt. You can figure out left to right directions, you can figure out QP, QS, and then pulmonary vascular resistance if by echo. If one of the easiest way to remember is if you do an MRI and the QP/QS is 3 or 4, in terms of them having a pulmonary vascular disease and them needing a cath all the time is debatable, because if you have a high pulmonary vascular resistance, there is no way the patient will have a QP/QS of 3 or 4, and you might not need to do a cath, but institution specific and cardiac surgeons might request it. If they're already 40-45 years old, they want to make sure, and sometimes they also require coronary artery imaging if they're 40-50s, to make sure there's nothing that they have to worry about. So what's my advanced imaging checklist for VSD is pretty much the same as the ASD here in terms of stuff, except you want to make sure that the dilatation is on the left side. So switching gears to patent ductus arteriosus here. This is the PDA of pediatrics, not the adult PDA. And communication between the aorta and the pulmonary arteries sometimes can be still there when they are in the adults, And when you do the short axis view in the echocardiogram, if you see the RPA, LPA, but you see some flow at the junction of MPA and LPA, where the duct is usually entering the pulmonary artery, and you see some flow going in this direction, of course, one of the differential diagnoses on the top of your list should be a PDA that is not closed, or it's persisting. Of course, a coronary fistula can also present this way, but you will figure it out based on the exact location and things like that. So natural history, if you don't read them, they can cause some left-sided dilatation, and the concept to understand is it's an endarteritis more than endocarditis. The fact that this hits with such a, here we are talking about 4.2 meters per second. You're hitting the pulmonary artery here every time, and this is an artery, and that's the infection, or the arteritis is where it comes from. Endarteritis, now the endocarditis. And you can also have ductal aneurysms. So management for adults, obviously, when you see that, if it's hemodynamically significant, which is left atrial, left ventricular dilatation, QP to QS might be higher, or symptomatic, you can conveniently go and device close that or surgically close that. I wouldn't think why one would do a surgical closure when we can easily do a device in the adult population. So coiling going here is pretty easy. This is the aorta. The duct used to be here because the duct is usually opposite to the left subclavian on the aortic side, and the pulmonary end, I told you, it is at the junction of MPA and LPA, and that's what makes it a duct rather than an aortopulmonary collateral, which is basically physiologically the same thing, but anatomically where it resides is what makes it a PDA. And then, of course, a device is placed, and just for sake of showing good images, we click that one. So the diagnostic and therapeutic recommendations is here, but out of which I took that out here to show that the PDA closure in adults is recommended if there is left-sided dilatation with a net left to right shunt and the PA pressure systolic 50% lesser than the systemic, and pulmonary vascular resistance is less than 1/3, and the pulmonary vascular resistance can be calculated by getting a Doppler across the main pulmonary artery and using the right ventricular ejection time and pulmonary artery acceleration time, and then the PVR can be calculated that way, even though that's not the most accurate in echo, but that can give you a surrogate. You can get pulmonary artery pressures from the TR jet. So by doing the TR jet, by doing the PVRI index by echocardiogram, you can get a sense, and if it's still questions, one can cath. So PDA closure should not be performed in adults with net right to left shunt and a PA systolic pressure greater than 2/3 systemic, or pulmonary vascular resistance greater than 2/3 systemic. So those would be the things that one would ask you guys. So what are the advanced imaging checklist? Again, going through this, you can get to figure out where the duct is and the QP to QS. The one tricky thing here, which I think one should listen, is the QP QS measurements in this case. However, the QP measurement in this case are measurements across the aorta, and the QS measurements are across the main pulmonary artery, because the pulmonary artery joins, the PDA joins the pulmonary artery way after we do the pulmonary artery measurements in the usual sense, which is right above the pulmonary valve. But the extra flow that got added from the PDA makes it to the lungs and then goes down to the mitral valve, and that actually goes down to the aorta, and whatever comes back from IVC, SVC, and goes to the main pulmonary artery. So that's a little bit when people are interested in getting QP, QS in an MRI for a PDA, one should just be cognizant about this, that they are switched in terms of the QP, QS, in terms of where they got. If you remember that for PDA, for advanced imaging, I think you got it. Atrioventricular septal defects, now as you can imagine, it's just a combination of the VSD and ASD that we just spoke, but the ASD is primum defect here, and then the VSD will be an inlet defect here, and the valve can be common, and based on how it is obviously normal here, and here if it is only primum ASD and a cleft mitral valve, we call it partial, and if it's primum inlet and a common AV valve. We call it complete common AV canal. So the checklist again is figuring out where those defects are, what kind of regurgitation is there if possible, if we get that. But post-operatively, when you image this, one should be aware that the way the aorta is kind of wedged in these patients, there is LVOT which is narrow, and they're prone for LVOT obstruction from that. And there's also a substrate from the left AV valve that have chordae that can attach, and is very prone for left ventricular outflow tract obstruction, and one needs to be aware of that one. Coarctation of aorta is a discrete narrowing or a long segment stenosis, and clearly one suspects from upper extremity hypertension, and there's difference in the blood pressure, and of course pulses in the femorals are not very well felt, or incidental finding when something was being done. This can be figured out very easily. Echo is extremely poor coarctation of aorta in the adult population, but once you get a flash CT, which should be very, very less radiation, all the way to sub-millisievert radiations, and you can do an MRA, either SSFP or contrast enhanced MRA, and you can figure out every details, including the way it is, including collateral flows, including if there is any other abnormalities of the arch, so on and so forth. Associated lesions, once you suspect coarctation, any left-sided lesions, if you suspect, you just have to run your quick checklist starting from the mitral valve, papillary muscles, aortic valve, and the whole of the aorta. That's just a given in the left-sided lesions. Diagnostic methods, the echo will be suspicious of coarctation if there is a huge gradient and the descending abdominal aorta pulsatility is not good, and you can figure out by MRI CT. And this is a 17-year-old girl. We had almost 2 or 3 of them in the recent past. Upper extremity hypertension, they go in for ER for something else, and then you get clearly no pulses, and then you see coarctation there. And then you can get CT scan imaging for morphology. In MRI, you can get the anatomy, you can get the flow in terms of gradients across it, and you can also calculate collateral flows if there are, suggesting stuff. So if there's, they can hold breath, you can get most of the stuff by MRI, and you don't have to do CT with radiation. And once you figure out this is an adult patient for the most part that you guys see, so the recommendations can be just a stent for native coarctation that has been first diagnosed. In the neonates, we are still not doing neonatal stent placements. We do surgery, but in an adult this age, we can put stents which can be dilated. Even though it looks very thin, you can bring them back every 6 months and dilate it. So recommendation for coarctation of aorta is initial and follow-up aortic imaging using CMR and CT is recommended with coarctation, especially who have had surgical or catheter intervention. And surgical repair or catheter-based stenting is recommended for adults with hypertension, and significant native or recurrent coarctation of the aorta is the take-home message from this recommendations. So post-operative complications, people wonder if there's already coarctation and it got repaired or stented, why do we have to follow? Because of the risk of aortic aneurysms and the risk of aortic dissections. One has to follow this every so often. Then switching gears to the complex heart diseases, which was not really the scope of today's lecture. I just wanted to put this, since it's recorded, people can watch it or see it. If you have a Tetralogy of Flow patients and they come for post-operative and you're doing advanced imaging studies and you're looking for this, the things in the black are the things that you're looking for, and the things that MRI or CT, based on what you do, helps. So if you see a residual VSD, you can figure out by that. Always we're looking for pulmonary regurgitation, so flow across the main pulmonary artery will help you with that. And diastolic volumes, if it crosses more than 150 mLs per meter squared, surgical indications or cath indication for pulmonary valve placement. And you can also learn to do branch pulmonary artery flows and differential flows, so you can see if one pulmonary artery is getting more than the other. And the rule of thumb is if the differential flows crosses 75-25%, that means if one pulmonary artery is getting less than 25% of the flow coming out of the main pulmonary artery, there is indication to intervene with stent placements and things like that. So you might want to calculate branch PAs and delayed enhancement. You guys know more than us. And aorta pulmonary collateral flow using several flows, which might include pulmonary veins, SVC, IVC. We can calculate an aorta pulmonary collateral burden, which is a left to right shunt, and we can close those collaterals. And that might be unrecognized if you just see an echo where there's no AST, VST, and it seems like everything is okay, but then still there is some amount of dilatation in symptomatic patient. Coronary artery anatomy can be sorted out by 3D SSFP MRI, so no contrast, and you can do that if you need more in terms of spatial resolution and accuracies down into the distal coronary arteries. You can do CT and the aortic root and the ascending aorta size. You can use MRI or CT, even though we know that Tetralogy of Flow patients, as opposed to other aortopathies like bicuspid aortic valve malformations and Lewy-Dietz, will not have a problem of dissection even though if they reach 5 centimeters. So this is a picture of a Lecompte Maneuver after transposition, where you see the pulmonary artery actually straddles the aorta here, and you can see that when they do this procedure, the stretching happens in the branch pulmonary arteries, and you see how one of the pulmonary arteries can be narrow, and you might want to use the differential flows. Detransposition of the great arteries here. This is the checklist of what are the things that one needs to do for an atrial switch operation. This is the checklist for an arterial switch operation. What are the things that can go wrong, and what are the things that we can help answer. And the miscellaneous is scimitar syndrome, which is where you shoot blood into the right pulmonary artery, and all the pulmonary venous flow is coming back into the IVC here, and this one looks like a scimitar here. In the chest x-ray, that's how it came up, is a Turkish sword. So that can sometimes cause right ventricular dilatation and right atrial dilatation. So you're looking for anomalous veins. If you don't see an ASD in adult patients with right atrial and right ventricular dilatation, is one of the things to just think in the back of your mind. Abstinence anomaly, very good for MRI in terms of figuring out where the displacement is, what part of the ventricle is atrialized, is there any tethering, what are the volumes, what are the QPQS if there is an AST, because they can have a right to left shunt. So it's a good modality to get this. Coronary fistula sometimes can be done with stuff when you do a regular CT and MR. This is also a left to right shunt. If it's very, very bad, you can have this, and then you can go coil the coronary fistula. So now switching gears to, these are all the things that mostly people have done, MRI, CTs, but how can we also put this into 3D printing and make it more easier for understanding and for surgeons and stuff. So 3D printing, I'm just going to show you how 3D printing is done. You basically obtain a CT images or a cardiac MRA images and then upload it, segment the heart, and once you segment the heart, you can convert it to an STL file, and once you get an STL file like this, you can just make sure it's all good, and you can hollow the model. It's all done on the computer at this point, and send it to a printer, and the printer takes anywhere between 3 hours to 18 hours, and then you can clean up all the support materials right there, and then you can test and get the whole heart model printed for you to understand and for you to actually do surgery or even practice cath in the adult side. So once we do that, we can print this for education, and which we do in our lab here, where you can color code it and also do complex heart models to show. This is the material that we print the heart, so as you can see the VST right there. This is the left side you're looking at. This is the whole heart. This is a double outlet right ventricle, where you see the aorta and the pulmonary artery both coming from the right ventricle. This is left ventricle, right ventricle, and this one is to show how you can baffle this VST into the aorta that's on that side. And I will show you that one video. This is the left pumping chamber. This is the right pumping chamber. Okay, so I think, and then We also can use the models, taking it to the cath lab to see if we can place stents, and it will not affect the coronary arteries, or the stent can be there where it is. This is a transposition patient that we wanted to put an artificial pulmonary valve, but we are not sure whether it was going to stay there or not, so we printed the patient's model, took him to the cath lab, the model, and then looked at the feasibility. So we do that here. We have also expanded now, after doing 3D printing on a regular basis, to help the surgeons and the cath people. Should we print every model, or we should just go for extended reality? And we do augmented reality, virtual reality here. So virtual reality, how are we using this? We can get all the kinds of models that from the patients, and then put it in the virtual realities environment, and then actually have all three models. And once you wear the goggles, you can use these and then understand that with your own time. And we can also insert all the study material. So if you want one module to learn about complete TGA, you can just come in about 30 minutes. You will learn the PowerPoint, and then you can actually play with the model, and you can see the inside out. So virtual reality in action.
Hello, welcome to our virtual operating room. My name is Jordan Harzma, and I'm here to give you a brief description of how 3D models can... Hello, welcome to our virtual operating room. My name is Jordan Harzma, and I'm here to give you a brief description of how 3D models can be utilized in a virtual reality space. So what we have in front of us here is the blood pool for a Tetralogy of Flow heart that's been reconstructed and put into our 3D space. And we have a few ways to interact and learn from this object that we've brought in. We can rotate it and reposition it if we want a different view. We can resize and move our object. And we can also use our 3D slicing tool to actually cut through the heart to get a better view. So if we were learning about our Tetralogy of Flow heart, for instance, we can use this cut that we've made right here to appreciate two of the four defects. We have a ventricle septal defect here and our overriding aorta here, with this being our left ventricle and this being our right ventricle. We can also import video and overlay echoes to get an even better understanding of our defective heart. So for our Tetralogy of Flow example, once again, we can actually appreciate those two defects. We have our left ventricle here, right ventricle here, there's the VSD, and there's our overriding aorta. So this is just one quick example of seeing how 3D models can be interacted with in our virtual reality.
So that has been very helpful for medical students to come and learn about complex congenital heart diseases, and also understand what the echo views actually mean and how they're obtained. And then, however, so from 3D printing, which is a little cost prohibitive, moving on to the virtual reality environment, I think we have achieved most of it. So that's helpful. Now, I think you still have to come to the lab to wear the goggles and go through that experience. So we said, why not? We try to do augmented reality and get it to the entire care team, that they can actually look at this and at any point, and most conveniently on their own phones. So we embarked on this. So complex heart diseases can be segmented out and then given a QR code, and then the QR code can be sent. So if people have iPhones or stuff with right now, they can actually point to this QR code, and then you can actually see the heart models that can show up on your computer, depending on the Android and the iPhone kind of iOS. If you scan this, and you will see that there will be a object mode, and then there will be a augmented reality mode. You can either see in one of this. If it's difficult for you to see in AR mode, you can see in the object mode. And then just like how you pinch to zoom and zoom out, and then how you rotate on the phone. You could do pretty much most of it. We are working on seeing if we can also use a slicing tool for people to slice, just like how we do in VR, and we're going to achieve that probably shortly. So I think in terms of understanding congenital heart disease and things like that, it does not have to be very complex, because there's more to come in these kinds of stuff. And then how do we transmit images to go to this? We can do a reconstruction and actually make it into a 3D PDF and actually send to whoever wants that. And okay, I knew it was not going to work, the link, because okay, that's fine. That was the last slide anyways. So 3D PDF is the next way of sending people information, so people can actually open that and click these things. And let me see if I can just show one last one. I know I'm exactly at time. I don't think people can see this screen here. So this is a 3D PDF. If I send people PDF form, you guys can just at your own computers can actually look at the models like this, not even doing anything. And this is a kid with the coronary artery coming from the same sinus with an intramural course. And you can see the slit-like orifice here, you can see the other orifice here, you can see the sinuses, high origin of the right coronary artery, and things like that. So this, and then you can have this root here. In the other model, you could actually take everything out here and look at the things. For example, this one, yes, so this one I can make it this. You don't want to do the rib cage, you can take it out. You don't want the LV, you can take it out. You don't want this, you can take it out. So this is how one can understand all of it in these days in terms of spatial orientation, and this is very achievable with what we do here. So I think this is all I had for presentation. I know at 11 o'clock started a little bit on the later side, but if anybody has any questions, I'm happy to answer. I will probably see the chat box. Stop share.
Thank you so much, Dr. Ashworth. That was a fantastic talk, and in particular, the last section about the 3D printing and augmented reality to learn. That's just fantastic. I think you have to come visit the lab and see some of these really cool tools you have. Just moving on to the next part. So I have here Dr. Young. She is our congenital heart representative for the Iowa Fit Council. Let me ask her if she has any, hello, do you have any questions or comments to ask Dr. Ashworth?
Thanks so much, Vikram. Dr. Ashworth, so good to hear your presentation. That was wonderful, and it's always good to hear all the good applications of the advanced imaging techniques. So that was a pleasure to watch. I know one of the other things that we always talk about, or is really important for us too, is when we're preparing for these procedures or these imaging studies, IV placement. And so I didn't know if you wanted to speak to that in terms of, you know, how important it is for our particular patient set that we think about where that IV placement is in preparation for contrast for those studies.
Yeah, thank you, Krista. So obviously IV placement is a good topic. So the reason that comes up for us in either patients without congenital heart disease and patients with congenital heart disease, what Krista is referring to is if patient have, let's say, for example, arch abnormalities, and then we are trying to figure out some of the arch abnormalities, and majority of them will have a left aortic arch, and then the branching happens exactly where the left innominate crosses the arch. Then you give a contrast into the left veins, left arm. Some of the times the contrast is so dense in the innominate that the subtle things that we are looking for in the aortic arch in that particular region get missed. So when we do the studies and when we are thinking of what questions to be answered, we are a little bit picky about where the IV has to go. So that's one of the examples. The other example is if you're doing a patient with single ventricle, especially which has a Glenn circuit, which is basically SVC connecting to the right pulmonary artery, and you're thinking of achieving contrast into the heart right away, and you put everything into your arm and you're timing it in such a way that you're doing it right after the contrast injection. If you time it based on the time, then you know that the blood will not even get to the heart. First it will go to the pulmonary arteries, and then it will go to the lungs, and then come back to the heart, and then to the aorta. So you might have missed things like that. And then if there's a patient with Fontan and you're doing injection in the upper extremities, then you might miss the lower part of the Fontan circuit. So you might have to do simultaneous upper and lower arm injections at the same time. And then the contrast, when you do it, because of the sluggish circulation, sometimes shows up as thrombus or some kind of artifacts, just because of the way the contrast was not distributed evenly because of all these kinds of complications. Then you have the other complex congenital heart disease where a coronary artery is coming off of a pulmonary artery, and then we are all used to getting coronary arteries by timing it at an aorta. You might not get anything because you missed the boat because the coronary artery is coming off of pulmonary artery. These are obviously very nuanced, congenital kind of timings. For the most part, when adults have gotten these patients, except single ventricle, I think we probably would have repaired for the most congenital heart diseases, which means 2 ventricles, 2 arteries. So the contrast can be as you guys use in adults. But if it's a complex heart disease, it might be worth thinking of where to give the contrast and how to give it dilution wise. Do you give it all at one bolus? Do you give it a third with contrast, a third with saline contrast mix, and a third with a chase with just a saline? So there's nuances. So I think the moral of the story is I would think about it, consult somebody just to make sure that things are okay. Yes. Thank you, Krista.
Okay, thank you.
Thank you very much, Krista and Ravi. That was an excellent review of all the congenital heart disease. We just included one talk this year for CT and MRI, so I requested him to kindly cover both topics for us. So thank you very much, and thank you, Krista. I'll move on to our next speaker, Dr. Carolina Zareba. Dr. Zareba is a cardiologist who specializes in cardiovascular imaging and treats coronary artery disease, hypertension, hypercholesterolemia, and women's heart disease. She works at the Ohio State Wexner Medical Center and has been rated in the top 10% of physicians in the nation for patient satisfaction. She is the Associate Program Director for the Cardiovascular Diagnostics Training Program, and her research interest focuses on MRI techniques to better diagnose cardiovascular disease. Thank you very much for doing this for us, Carolina, and she's going to be talking to us about non-ischemic cardiomyopathies.
Great. Thank you so much for the invitation. I'm really honored to be speaking today about non-ischemic myocardial disease. Let me just share my screen here. Okay, can you see my screen?
That looks perfect, Dr. Zareba.
Great, thank you. So again, thank you again for the invitation, and I'm excited to speak about cardiac MRI. This is a topic specifically in non-ischemic myocardial disease. This is a topic I spent a good deal of my time researching and of course seeing patients. So I'll focus on several diseases, as of course we can't really focus on everything within 45 minutes to an hour. So I have no disclosures. First, I'll just briefly speak about some tissue characterization. You've heard about this already, but I'll just speak briefly about a couple aspects of it, maybe from a different angle, and then I'll focus on these 4 cardiomyopathies. In terms of tissue characterization, really what I'm talking about, this is not an exhaustive slide or exhaustive list of these tissue characterization properties, but what I'm really talking about mostly are going to be late gadolinium enhancement imaging, T1 and T2 mapping, along with ECV, and how they can really help us in non-ischemic cardiomyopathies. So I first want to start with myocardial edema. So about 80% of the myocardium is water, and most of it is in the intracellular compartment. So if you look at this left picture here, you see these are water molecules. You can see as depicted here, and most of these are bound to proteins. And you'll see when you have any myocardial insult, this results in disequilibrium. And what you have is these bound water molecules become unbound and in the cell. And as this insult persists, then these cells become more permeable and you end up having myocardial edema, which is this excess fluid accumulation in the actual interstitial space. So I want you to think about myocardial edema as really imbalance between two things. So filtration from the coronary macrovasculature and then removal by the lymphatic vessels. And what you'll see is myocardial edema does impact your contractility. It can contribute to arrhythmias, but really most importantly, it also, when it is chronic, can exert this pro-inflammatory effect and in turn lead to increased collagen and interstitial fibrosis. So myocardial edema can really happen anytime. You know, we think classically of things such as sarcoid and, you know, inflammatory myopathies, we think of Takotsubo, but really myocarditis, but really any of these insults can cause myocardial edema. And this is an interesting fact from a very nice study in the early 90s. When myocardial fluid content is increased by 3%, your cardiac output is compromised by a whopping 30%. So again, myocardial edema matters and we can image it, so we should pay attention to it. Well, how do we image it? Well, briefly, this is essentially detection of T2 signal using cardiac MRI. This is a nice study back from the 80s in a canine acute MI model, looking at this direct relationship between water content and T2 signal. And they showed this, which was previously shown with T2 weighted imaging, but of course has now been shown with T2 mapping, which is predominantly one of the main techniques that is used. Briefly again about myocardial fibrosis. You've heard again about this as well in prior talks, but just think of it as a disproportionate accumulation of collagen relative to the cardiomyocytes. So this is serous red staining in an animal model with this interstitial fibrosis being shown here. And again, this is dysregulation of collagen turnover. When we're thinking about myocardial fibrosis, you know, first under these normal conditions, we have fibroblasts and they secrete this extracellular procollagen chains into the interstitial. These assemble into fibrils. And when you have a myocardial insult, you end up having these pathologic conditions which alter the matrix environment. What you have is fibroblasts becoming myofibroblasts. And these secrete collagen, procollagen chains that assemble into these collagen fibrils. These become cross-linked. And unfortunately, this cross-linkage is what makes them resistant to degradation by MMPs. And this, of course, results in cardiac disease. When we think of myocardial fibrosis, there's really a couple main pathways that we want to think about. So we have this fibroblast activation pathway, whatever the insult for that may be, whether it's edema, whether it's a specific disease process. And what you'll see is this fibroblast activation causes this interstitial, so reactive fibrosis that can be around the vasculature, throughout, in between the actual myocytes. And as this progresses, you can have LV myocyte hypertrophy, but over time, you can, because of this perivascular fibrosis, which is cutting off, can lead to cutting off significant vasculature to these myocytes, you can actually have myocyte loss. So again, here, interstitial fibrosis, and then this leads to replacement because it's replacing an actual myocyte. And this is, again, a more focal scar, replacement fibrosis. You can, of course, have this myocyte loss pathway. Think of your heart attack. you lose myocytes, and then of course that it activates your fibroblasts, and you have this replacement scar. This is just another well-known classic picture to look at it slightly differently. We again have these main 3 different types, which is this interstitial fibrosis, so you see between the cells, that can progress to replacement fibrosis, where you see myocytes are gone. Of course, things can go directly to replacement fibrosis. And of course, infiltrative disease, so we think of your amyloid proteins getting deposited in the interstitial space. Well, we know fibrosis is important, and why? Because it really affects both mechanical, electrical, but also vasomotor function. So you can have increased afterload and preload. You can have decreased perfusion reserve, abnormal conduction, arrhythmias, and of course, systolic and diastolic dysfunction. How do we image it? Well, you've heard a lot about this already. But essentially, we are looking at late gadolinium enhancement imaging for replacement fibrosis. So these foci that you see. So for example, look at this DCM patient with this classic linear stripe. And what we're looking at is relative differences in T1 signal. So here we have a relatively normal-ish looking myocardium, which is dark, and then this brighter area. And we'll see more of this. The problem with LGE for giving us a comprehensive picture is that it does not tell us anything about diffuse fibrosis. So yes, we can see patchy things, but we don't actually know if what we're comparing to here is normal or not. So that's where T1 mapping comes in. And that looks at the interstitial fibrosis. We measure this T1 signal, we look at pre and post contrast T1, and what we actually do is calculate this extracellular volume fraction. And what this does is looks at the amount of space in the extracellular space that is present within the myocardium. And just a note about the types of fibrosis, we know they coexist. They coexist both in ischemic and non-ischemic myocardial disease. And this is a study we did in over 1,000 patients where we looked at LGE, and you can see LGE is in the gray bars here. And on the x-axis is ECV, and you can see LGE can be seen, so replacement fibrosis, really across the spectrum of ECV. Most centers, I won't get into this in detail, but most centers ECV around 29 or so, or 30 is less than that is normal, and each center establishes their normal values based on their schema. So I'll move on to our actual diseases that we'll be talking about. Most of this relates to kind of the same sequences that we'll be using in most of these patients that you've been hearing about. So of course, cine imaging, tissue characterization, phase contrast imaging for especially some of the valvular assessment, strain imaging being more of an early marker, and in some cases, stress perfusion imaging as well in some of these patients. So let's start with DCM. I won't belabor this, but we're talking about ventricular dilation and dysfunction without abnormal loading conditions or CAD. We know that this etiology is very heterogeneous. Genetic variants are becoming a lot more prominent as we're discovering them, that they may make up a lot more DCM than we think. And of course, we know the sequela because we see these patients frequently. So CMR really is great with DCM because it, in terms of just purely even the cines, it is the gold standard for quantification of LV/RV. It is accurate, precise. We have, of course, age, gender, index values, but you know, there's really another aspect. Of course, we can see this picture here, the cine here on the left. We can see, you know, LV dilation and of course significant dysfunction. And we can see on the right here that we've got pretty decent function. Doesn't look too dilated either. But this mild abnormalities are actually important. So you see these are sort of low normal to mild, all with relatively normal sizes. And picking these up, especially in patients with DCM, is critical to really start your goal-directed medical therapy and accurately diagnose where they are on this spectrum. And you know, we actually know this that low normal LV function is not benign. This is a nice study of over 5,000 patients from the Framingham Heart Study. They stratified these patients by EF groups, less than 50, 50, 55, and greater than 55. What they found is actually that the low normal, 50 to 55%, again, this is by echo, group at 8-year follow-up was associated with worse outcomes as compared to the normal greater than 55 group. So looking at this for both outcomes of heart failure and death, but particularly that heart failure outcomes. So again, these small changes do matter. Looking at strain, well, strain and established DCM is of course abnormal, as you can see, longitudinal, circumferential, radial. But strain is actually different in DCM versus ischemic cardiomyopathy as well. We can see more circumferential strain abnormalities, as well as more torsion and twist abnormalities in these patients. T1 mapping, again, we talked about the interstitial fibrosis aspect. ECV is very well correlated with biopsy collagen volume fraction, specifically in DCM patients, both DCM and early DCM, so sort of that mild LV dysfunction. And this is again important because T1 can actually discriminate patients from both healthy controls, but even I would say more importantly, as we're seeing more athletes come to MRI labs, is distinguishing between pathologic DCM, but particularly adaptive remodeling that we can see with dilation in some of these patients. So this is again for both ECV and native T1. Myocardial edema in DCM, we think again of inflammatory myopathies, but we see myocardial edema in regular DCM as well. This has been shown in both mild DCM and severe, and then these T2 values elevated both with the T2 weighted imaging and the T2 mapping as well. And what you'll see, same thing, we can kind of help discriminate between DCM patients and athletes with elevated T2 maps. This is actually a very nice study. So it's not a large study, but it's a very nice study that took patients with acute heart failure and actually did cardiac MRIs with T2 mapping on presentation and post decongestion. They also did caths to ensure that these, the right heart caths, ensure that this was in fact congestion and that these patients were decongested. They had specific criteria in terms of wedge and everything for decongestion. And what you'll see here is your T2 signal. This is the actual T2 value from T2 mapping, was at baseline elevated and after decongestion decrease. And this is really the correlation here with wedge. So again, kind of a nice example to look at here. When we're looking at inflammatory myopathies or in general looking at T2, sometimes it's really hard to say, especially when someone is very wet and volume overloaded, whether that is related to their actual decongestion or to a different pathologic process. So typically we scan these patients when the ones that are a little closer to euvolemia and before discharge. Of course, LGE, you've all seen this slide, I'm sure. We're focusing on this right side here, and DCM, most classic is this mid-wall linear stripe. That's present in about 45 to 50% of patients, as you can see here, as we've shown before. And this is actually the most common presentation. So although we can see fibrosis in other areas, but this linear stripe is very classic for DCM, and you'll see this is not so the case with other non-ischemic cardiomyopathies. I do want to warn you though, CMR really helps identify and classify cardiomyopathies. And you see this patient with a pretty dilated LV here, pretty dysfunctional, some more slightly prominent trabeculae. But you can see they've got a pretty impressive infarct here in this infralateral wall. So again, potentially a mixed picture. So even though the coronary cath on this patient was normal, this was not the case in terms of their LG imaging. And just to mention here, we see, traditionally, as we know, the wavefront of necrosis goes from the subendocardium to the epicardium. So usually when we think of what is ischemic pattern LGE, we're thinking of subendocardial or transmural LGE that follows a coronary distribution. We do have to think of other things though when we are seeing these patients. So for example, Embolic can do this because you might have clean cats in these patients. You can have thrombus, of course, Emboli, you can have SCAD, you can have just recanalization of the artery and it looks good, but there was in fact something there. And then you can also have non-coronary causes. So thinking about a more kind of transmural scar, we can see that in various disease states. We can see, of course, sarcoid can do it. Amyloidosis can have transmural scar. We can Anderson-Fabry disease can have transmural scar as well. So just whenever you're thinking of it, and you see transmural, most classically or subendocardial, that's going to be CAD or an ischemic type process. But think of the caveats that can also be present. Of course, this is one of our seminal papers in MRI literature from Dudley Pennell's group, which looked at over 400 patients and showed that LGE, this midwall LGE that I just showed you, is really one of the strongest predictors of outcome in DCM and really predicts all variety of outcomes and rather significant outcome differences in these patients. The DiMarco performed this meta-analysis and included a lot of these studies and specifically focused on arrhythmic outcomes in DCM and noted that patients with LGE, and this didn't have to be a significant amount of LGE, this was in the low percent, less than 5% even was their mean LGE percentage, had a significantly increased risk of ventricular arrhythmias or sudden cardiac death with this presence of LGE. So same group, Dudley Pennell's group, took this further and looked at patients with mild LV dysfunction. So we knew that those classic DCM, less than 35% do worse. Well, what about those with mild LV dysfunction? And again, looking at this is just a median LVF of 50%. And patients with LGE had significantly more arrhythmic events, 17 versus 2% compared to those without LGE. So again, LGE helped risk stratify even those without severe LV dysfunction. And this is an important aspect as well. We are also learning that LGE extent and location matters. So I mentioned to you low percentage is enough to cause events, and this is showcased here with this sort of nonlinear relationship where even small amounts are associated with outcomes. And what they've shown is really once you have septal and free wall LGE, that is associated with the greatest sudden cardiac death risk. So a question that I often get from my patients is really, does fibrosis go away? And this is a very nice recent study, which really looked at 85 patients with DCM, and they performed MRIs about 1.5 years apart. And what they've shown is that patients at baseline, about 40% had LGE, and 0 of them had regression. So really no LGE regression of this replacement fibrosis. However, 18% had LGE progression, and this was from about, excuse me, 1.8 to 6.3% of myocardial mass, so LGE quantification here. And what they showed is that this progression was associated with worse remodeling, but interestingly, it was not really associated with a significant change in EF, but it was associated with worse outcomes in terms of mortality and heart failure complications, as you'll see here. So the thought was that this LGE progression identified this high-risk cohort. So scanning these patients, again, can potentially help us figure out who is going to do worse as compared to the other cohort of stable LGE patients. Thinking about another aspect that we're seeing more and more in this DCM group is this ring-like LGE. So I want to kind of point your attention here to all of this white that's here. That's actually myocardium. That's not pericardium here, and as well here, and that is actually fibrosis. And as you can see, rather prominent. It can be sort of midwall to epicardial. And what they found is that patients with LGE, with this ring-like LGE pattern, tended to do far worse in terms of arrhythmias and in general survival. So here again, no LG in this green line, LG but without ring-like, and then ring-like LGE. And they looked at this also in terms of the scar burden, and they noted that patients, even with low scar burden, in terms of how much of their LV has LGE, those with spring-like LGE tended to do worse. And this is an interesting study from James Moon's group, who actually looked at these patients with ring-like LGE and did genetic analyses and found that really the this impressive LGE was focused in patients with two variants, so desmoplakin and filament C. So again, high concern for arrhythmic events in these patients. And, you know, obviously, as we're learning more and more and seeing genetic data on more of our DCM patients, especially when you're seeing these variants, may pique your interest to perform CMR and really look at this to help evaluate their risk. And really lastly, pertaining to DCM, the value of T1 mapping, both native T1 actually has been shown to be a strong predictor of outcomes in patients with DCM when it's abnormal, when it's abnormal, but it's also when it's increasingly elevated. And the strength of this was actually much stronger than looking at LGE and of course LVEF. So in summary, CMR and DCM is great in terms of cine imaging for accurate and precise analysis. Midwall is the signature of DCM, midwall LGE. And then LGE presence, even in small amounts, is associated with adverse outcomes. And of course, parametric mapping helps both in diagnosis, but especially of early disease, but also in prognosis. So I will move on to hypertrophic cardiomyopathy in this whirlwind of non-ischemic disease. Again, you all know about hypertrophic cardiomyopathy. We have LVH, again, unexplained by loading conditions, no LV dilation typically. A lot is genetic, where, you know, we have a lot of patients we don't have the genetic variant identified in, but sort of classic pathologic and phenotypic features. We can see many different types. We, you know, have things on various aspects of the spectrum of HCM. And of course, we know about multiple sequelae, including LVOT obstruction, ischemia, and this is sort of where stress CMR can help here in patients with HCM having a not rare microvascular obstruction, microvascular dysfunction, not obstruction. Of course, heart failure, arrhythmias, and sudden death. So in terms of cine imaging, you know, we really like cine imaging in HCM because it can show us not only the actual degree of LVH, but also the location, because sometimes it's hard to really visualize these things with other imaging modalities, especially when it's not classic, such as this one, which is really, you know, HCM more of the inferior wall. We can have RV involvement. We can have crypts, which are fairly common. We can have aneurysms, and of course mitral valve abnormalities. So now here we have this sort of mid to apical variant with an aneurysm. Here we have a prominent apical hypertroph and two septal hypertrophs that you see here. And phase contrast imaging is really helpful in these patients because we can look at this mitral valve in detail. So, you know, I want you to look at this regular cine here first. You'll see, of course, this hypertrophy. You'll see this mitral valve, which appears a little bit elongated, a little thickened, which of course you see this LVOT flow acceleration here, this jet, and you see this systolic anterior motion of the mitral valve. And what we can do in these cases, of course, we can do cross sectional through plane imaging to get direct velocities, but we can also just simply look at in-plane imaging. And what I mean by that is just, again, looking at this nice jet. So you have this magnitude image and you've got these phase contrast images here. This one was at a velocity set at 1.5. This one's at 3 meters per second. And you can see that this is a significant LVOT outflow acceleration here, since we are still what is called aliasing, just similar to what you think of an echo, already at 3 meters per second. So this can really help us get to the bottom of alveolar obstruction. And of course, we can, of course, do a through plane here and get the actual velocity in detail. LGE, again, really another aspect that's key for diagnosis and risk stratification in HCM. Most commonly, it's in the hypertrophied segments. Locations mostly in the septum and RV insertion points, but not always. So I want to show you these examples of these cinemas that I showed you earlier. Here we have this septal hypertrophy patients with really a striking amount of fibrosis here. Here is a patient with this apical aneurysm we looked at, and look at this amount of scar that they have in this apex. You certainly may worry about clot formation in this apex. But, you know, I think the power of CMR really helps us risk stratify these patients, because look at these two apical hypertrophic cardiomyopathies. This, of course, striking hypertrophy, but there's fibrosis there. But in comparison to this one, which is not as thick, and look at the amount of scar burden here. So again, not something we can guesstimate by just looking at the amount of hypertrophy. And this LGE is important in terms of risk stratification. This is one of the earlier papers, now over 10 years old, showing us that LGE presence, just presence itself, was associated with all-cause and cardiac mortality. Patients with more LGE had more events. Really, patients who had no classical risk factors also had LGE. So of course, the Chan paper from 2014 classically kind of told us that the extent does matter. So patients with greater than 15% of this LGE of their myocardial mass demonstrated an increased risk of sudden cardiac death. And this was even in patients with thought to be at low risk based on the traditional risk factors. So all of this actually led to a nice editorial by the Marin family, and they really urged the community, this is in 2016, to start incorporating LGE into these risk stratification of HCM patients. And again, this is 2016. And then in 2018, we came out with these guidelines, which again, focused on LGE and incorporated these modifiers, which LGE was one of them. So, you know, this research, as we know, leads to changes in guidelines. And yeah, I think the similar is going to be the case for DCM. We're not quite there with our guidelines, but this research does change guidelines. Lastly, note about T1 mapping in HCM. This is an older paper, but a very good one by Rocio Hinahara, and looking at early hypertrophic cardiomyopathy, how T1 mapping can discriminate between hypertension and hypertrophic cardiomyopathy, but also those that are genetically at risk. So we're talking about those with the genetic variant, but no actual LVH phenotype, and versus controls who also have elevated T1 mapping, these genotype positive, phenotype negative patients. So again, CMR can really help identify the pattern of hypertrophy and the degree of it. Phase contrast imaging can help you in valvular and gradient assessment. We can look at various LGE patterns to help us really risk stratify and provide better prognostic information in these patients. Moving on to cardiac sarcoidosis. Again, we know this is a granulomatous disease, can be seen in up to 30% of patients in terms of the cardiac aspect, and 30% of patients with sarcoidosis in general, thought to be immunological and genetically based. Of course, we know conduction abnormalities, arrhythmias, heart failure are all possible sequelae. T2 mapping is really helpful, edema imaging, as we can call it, in sarcoidosis because of the inflammation that happens in cardiac sarcoidosis. So you can really identify this water content, because this is exactly all we're looking at, as I showed you initially. And what's impressive is this is a study done by Suvaraman, which looked at patients, sarcoidosis patients, and looked at those that didn't have ECG or EP abnormalities versus those that did. And T2 mapping was significantly higher in those with these abnormalities. So the thought is that this can potentially be an earlier reversible stage of disease and can obviously be potentially targeted with therapy. So here's an example of exactly that. We have a patient with cardiac sarcoidosis, pre-immunosuppression. You see this brighter area here of elevated T2 signal. This was on our older magnet, which normal was less than 59 milliseconds. So again, elevated here. And then after several months of immunosuppression, this improved. So again, helps follow response to therapy as well. When we're looking at LGE, this is a little bit trickier. We see a lot of patterns. So here are various patients with confirmed sarcoidosis. You see this patchiness, you see these subendocardial, you see this transmural, you see epicardial patterns really can be striking or even mild. And you of course know about these patterns and these non-coronary distributions, but it can be more subtle than this. And here's a nice example where you can see this classic septal involvement. You can imagine how this is causing conduction abnormalities, and this almost to me looks like a granuloma here in this short axis slice. So again, lots of different abnormalities are possible. And then this is sort of the other half of that study I was showing earlier of DCM patients, where you see patients with DCM really mostly have one of this midwall stripe fibrosis. There's of course exceptions, but most of the time. Now in sarcoidosis, you can see all these patterns. Does not have to be at all one kind. So that makes, again, knowing these patterns, looking at inflammation, presence of inflammation, edema, and putting it all together is what sort of helps us diagnose cardiac sarcoidosis. Again, LGE is important in this patient population, so also associated with outcomes, both with actual mortality, but importantly also with arrhythmias. So look at this graph here, looking at patients with LGE in the white bars and without LGE in the dark bars here, and looking at, and again, these outcomes being significantly different. And same with here, this is all-cause mortality, and this is all-cause mortality plus ventricular arrhythmias. And again, another risk stratifier, as we know, cine imaging is gold standard for function, and RV function is hard to obtain as accurately as is with CMR with other modalities, hence knowing this function, because if you look, even just less than 40% RVF has significant decrease, decrease in mortality in these patients. So again, another risk stratifier. And this also made it into our guidelines. Looking at extensive scar by MRI can help sort of risk stratify for device therapy. Excuse me. So conclusion about sarcoidosis, really one of the most sensitive and specific tests to detect it. T2 mapping is key here, and just know LG patterns are heterogeneous. Okay, last topic will be cardiac sarcoidosis. We know this is, of course, extracellular deposition of amyloid fibrils, predominantly AL or ATTR, and can cause really a myriad of sequelae, heart failure, arrhythmias, and of course death. The most classic thing we see is concentric LVH. It can really be all patterns, though. We can see it eccentric, we can see asymmetric, we can also not see LVH sometimes. We can see IV hypertrophy, of course, here you're also seeing pericardial and pleural effusions by atrial enlargement. The key part is EF can be really normal, and we see this often. It can be normal even into late stages of disease. And also one thing to remember is we of course hear about MAPC and just poor annular motion, as you see in this top picture here. Really, annulus not moving, but things are moving. And this is a basal to apical disease, meaning we really see abnormalities first at the base. LGE is really classic for cardiac amyloidosis. These are pictures of cardiac amyloidosis that's fairly significant and end stage. You can sort of see this basal to apical predominance in this patient. Here's this classic diffuse subendocardial, and this is really, in this first patient here, it's really hard to tell where the blood pool and the myocardium begin. And then you may also hear of this train track appearance where you have this subendocardial, epicardial. And again, you can see different patterns, but usually very extensive. We talk about ultra-Galilean kinetics, and that really relies to the fact that we are unable to know this myocardium because of this extensive enhancement. And what's really happening here, because as you remember, this is all this interstitial space that's taken up. So there's more and more interstitial space because it is taken up by amyloid proteins. And that is exactly where gadolinium hangs out, is in the interstitial space. So T1 mapping has really revolutionized amyloid diagnosis. Since we know it's an interstitial disease and T1 mapping looks at an interstitium, it has helped us tremendously. So really looking at your degree of suspicion, looking at the pattern of LGE, and then looking at what your ECV is. Usually when you're getting into the high 30s and 40s, you really have to start getting suspicious for cardiac amyloidosis. And this is an example of normal ECV here of 25% versus 82%, which is just tremendous amount. We've done some work looking at using CMR to see if we can distinguish between AL and ATTR. There's papers along with ours and multiple other papers that have looked at really the differences. We know that ATTR has more LV mass, lower function of both RV and LV, larger volumes, worse strain, and also higher ECV, and also lower T2 signal. The thought in terms of T2 is that AL is really more of a cardiotoxicity that the light chains produce, which increases T2 signal and causes increased inflammation and edema. The extent of LGE, although hard to quantify with just visual evaluation of LGE, but certainly pattern-wise, the extent is associated with worse outcomes. If you're looking at here, no LGE versus subendocardial versus transmural LGE, and by subendocardial, we're talking, of course, that classic pattern of diffuse subendocardial. And again, the challenge of quantifying this really is how ECV helps us so much in terms of providing this information of this extracellular space and showing that patients with higher ECV, both in AL and ATTR, tend to do significantly worse. So again, the more accumulation of the amyloid protein in the interstitial space. And T1 mapping has actually been helpful in looking to respond to therapy, for example, in AL amyloidosis. This is also starting to be shown with therapy in ATTR. But if you look here, you can have, in this patient, you can have this extensive, you can see all of this white, this extensive enhancement, this extensive LGE. We don't call it fibrosis in this case. We usually like to use the word enhancement, since fibrosis seems to more imply collagen, and this, of course, we know is there's certainly some collagen, but a lot of it is actual amyloid protein. So we do use enhancement more of a term there than fibrosis. But here you can see this nice regression, and whereas here you can see impressive progression in this patient. And we're involved in some work looking at actually this with tafamidis and ATTR patients. So again, CMR can distinguish amyloidosis from many other causes of LVH, can have different patterns, and I'm sure some of this will be on the boards in terms of that classic diffuse subendocardial pattern and that base 2 apex disease. And again, T1 mapping really helps quantify this burden and is also highly prognostic. So in the last few minutes here, I want to have one slide about Anderson fiber disease, and there's a reason for it. We know this is an X-linked lysosomal storage disease, and we know it can cause conduction abnormalities, arrhythmias, death. But why is CMR important in it? Well, we see LVH, which is typically concentric, but what's really helpful with T1 mapping is we know T1, as we just talked about, is significantly elevated because amyloid protein elevates it in amyloidosis. We know it's elevated in other disease entities too, but not to this extent. However, what happens is the fat that's in Anderson-Fabry disease, especially in the earlier fat deposition stages when it doesn't become all collagen, then you can have T1 lowering because fat naturally lowers T1 signal. So you will see lower native T1 signal as is depicted here. And then as this disease progresses, you can see impressive sort of nearly transmural, mid-myocardial, but nearly transmural fibrosis, typically in that basal infralateral. So again, looking at the extremes of T1 with native T1 mapping can certainly help as well. So just finally looking at these patients, all of these patients have LVH. All of them have varying degrees of, I guess, LV function, some normal, some abnormal. But, you know, looking at these patients, it's really hard to come up with a true diagnosis right away, and especially risk stratification too. So I think this is where MRI can really help us with non-ischemic cardiomyopathies. And we are very frequently, you know, surprised with what we're seeing when something is just called, oh, a DCM or a non-ischemic cardiomyopathy, and then we dig deeper with cardiac MRI and with particularly tissue characterization properties and find many more answers. So these patients that I've just shown you, this first one is an amyloid patient. This unfortunately is a very extensive amyloidosis where you see this is fully enhanced myocardium. Here's an Anderson-Fabry disease patient with very low native T1. Here's your HCM patient with some LGE in the apical segments, and here's a hypertensive patient with some coronary disease, and you can see there's an apical infarct as well as an LV thrombus. So again, tissue characterization is key and is helpful for distinguishing all of these different diseases that we spoke about today. So that is all I have. Thank you. Think like a proton and stay positive. Thank you so much.
Great. Thank you so much, Dr. Zareba. That was a fantastic talk and really high yield for, especially for fellows. So thank you so much for sharing that with us. The next few minutes, we're gonna try and go over some of the questions that we have in the chat. Let me first just quickly check with Dr. Ashworth to start with, if she has any comments or questions she would like to ask.
You can go ahead, Vikram. I think there's a few
Okay.
questions in the chat. Yeah, go ahead.
Sure. So the first question I have is, are there any studies showing the percentage of HCM patients who have negative LGE to start with or become positive on follow-up studies?
Are there any studies? So there are some studies, smaller ones, but predominantly we have one-time time points in these patients. So sort of this is the goal of the HCM, large HCM registry, is to show that and to show these people. We have cohorts at OSU looking exactly at that and showing this progression. And what we've noticed, and this has been published too, is that unfortunately younger patients can often progress more than we see than, let's say, older HCM patients with the amount of fibrosis. So it is worth re-imaging these patients. Do we have an interval that we know about? Not easy. I would say 3 years is one should probably re-image these patients if it's going to change management.
Okay, great. Thanks for that comment. So let me look at some of the other questions. Are there any other cardiomyopathies beside amyloid that would give subendocardial global LGE with abnormal blood pool GAD kinetics?
Yeah, so great question. The most classic one you'll see is amyloid. That's the only one that will be on your boards for that pattern. However, yeah, you can. And what this, abnormal blood pool gadolinium kinetics refers to really we typically think most associated with amyloidosis, which it is. But if you have diffuse extensive fibrosis that is throughout, then you're going to have a very hard time nulling your myocardium after you give gadolinium. So you might see this similar pattern. I actually have a patient that we are dealing with this currently, who has a tropomyosin variant, not even a established variant, but tropomyosin variant, and I just re-MRI'd him, has extensive fibrosis. I can't rule out HCM at this, amyloidosis at this point, but I think it's, for example, this HCM ish restrictive variant of tropomyosin. So we're seeing that for sure. And his is really kind of more patchy diffuse. In terms of diffuse subendocardial, most likely you're going to see that with, especially diffuse, you're going to see that with amyloidosis. If it's really bad sarcoidosis, obviously we know subendocardial can be sarcoidosis, so you can certainly see that, but usually it's not as diffuse as those images that I showed you from amyloid.
Sure, thanks for explaining that. The next question we have is, when measuring native T2 times, do you usually have several ROIs to avoid missing regional patchy areas of inflammation?
Great question. So I'll comment actually on T1 first. T1 is a diffuse process, or excuse me, interstitial fibrosis, we like to think is more of a diffuse process. So in T1, for clinical purposes, not research purposes, for clinical purposes, as is recommended by Cmr guidelines, we typically do a mid-short axis septal region of interest, where we try to take really all of the septum. Of course, super careful not to have pressure volume from the blood pools on both sides. So we definitely don't go too close to the blood pool. So that's T1. Now T2, totally agree with you. Regional can be totally regional. So yeah, we definitely do. Our T1 maps help. We do. We typically do for T1 and T2. We typically, and everybody do for cardiomyopathy evaluation, at least base and mid. We typically avoid the affects. Again, partial volume, not as helpful. But we also, for T2, especially if we have concern, we always do the 3 long axis slices too. And that helps us because we want to make sure, one, there's no artifacts. And of course, if we're seeing something in the infralateral wall, we better be seeing it on the 3-chamber too. So yes, so we do draw specific regions of interest where we see it visually. That's where the maps help us. The other aspect is following a Cmr guidelines, making sure your ROIs anywhere you draw are at least 20 pixels. So yes, definitely, because we can certainly draw 5 pixels and we get a pretty high T2, but you don't want to do that. So we've actually have a T2 review coming out in JCMR in the next couple weeks to months. So look for some details on T2 mapping there as well.
Okay, great. Yeah, we look forward to that paper.
Thanks.
Let me look at our next question here. Is there any prognostic implication of atrial valve fibrosis in any of these infiltrative cardiomyopathies? Can it be seen in isolation, for example, in patients with isolated biatrial enlargement?
Good question. I don't know. I'll be honest, I'm not an atrial fibrosis expert. Although we've TCAF trial involvement, we've done all that, but I would say so I don't know if in terms of specific prognostic information in these non-ischemic cardiomyopathies. I will say that from sort of clinical experience, typically we don't see this biatrial fibrosis immediately, the striking where we even comment on it in our reports, this striking biatrial fibrosis in amyloid patients initially. Usually we see that later in their course of disease. And once you see that, yeah, I mean, but this person is usually their ECV is 60 or more, and you're having we're even seeing RV involvement at that time. So definitely, it's definitely possible. I would presume that it may have prognostics implications because it may actually show just a later stage of disease. And I see there's another question about amyloid about in terms of whether it can occur without LG. Yeah, you can. And that is a hard thing for us to diagnose. Normally, unfortunately, these are patients that are let's say ATTR positive, that we're screening them. So we have patients that we, I'm talking about gene positive, of course, that we are screening them sequentially with MRIs and looking to sort of identify this early. But we do have patients that are biopsy positive and have very minimal LGE, and of course, you know, that's challenging, but thankfully that is a good thing for the patient. So you know, great timing to start these targeted therapies.
Excellent, thank you so much. So, you know, thank you for answering all those questions. That was excellent discussion. You know, to me, it almost seems like corneal angiography is always part of the evaluation for cardiomyopathies, but I feel like cardiac MRI should really fit in somewhere upstream of that process. And, you know, in the current era, it should be like essential part of that assessment.
Yeah, sorry, I'm in the hospital on service, so didn't want you guys to hear my overhead. Yeah, I fully agree. I mean, I think, you know, obviously per our guidelines as well, CMR can help you so much. And I think, you know, rotating through the CMR lab, you'll see how you're like, oh, okay, well, you're just gonna see, okay, it's your DCM, you're gonna see mid-wall fibrosis. Well, it matters because you're seeing DCM without fibrosis, and you're gonna be more scared of that patient. And nowadays, not that things are changing, but because more MRIs are being done, then, you know, sometimes you'll see this ring-like pattern, and you're gonna be calling that physician, and you're gonna be telling them, listen, this looks bad, this is significant, this is gonna, we have studies that show this is gonna impact this person significantly more than non-ring-like LG. So I think even when we feel like, well, what is this going to show? We're surprised. We're surprised often. So yeah, I agree with you that CMR is key in these non-ischemic cardiomyopathies.
Great, thank you so much.
Thank you very much, Carolina. That was an excellent review for the viewers. I think just like Dr. Chenoy pointed out, that mapping doesn't have too much value in masses. Dr. Zareba really brought out the value of mapping in cardiomyopathies, more specifically non-ischemic cardiomyopathies. So it should totally be part of your protocol for the non-ischemic cardiomyopathies. I just had one question, Carolina, is for patients with, especially if you're thinking acute sarcoidosis, do you do scar quantification? And if yes, when do you do it? Do you do it at that point, or do you bring them back and after the inflammation is gone, then do it? Or?
That's a great question. You know, I think in any inflammatory myopathy, it's always hard to know what your final scar burden is going to be once the inflammation resolves. You know, thinking even just of myocarditis, but at sarcoid, we don't do scar quantification typically in our sarcoid patients. We sort of obviously talk about it. We talk about more segments. We're not doing, you know, 5 standard deviations or full width half max in these patients classically. And part of that is, you know, a lot of them, exactly as you say, have inflammation, that we're seeing these patches of inflammation. And part of that, you know, we don't really want to call it. Do we bring people back post immunotherapy? Yeah, definitely. And we look at it then. Again, we don't quantify it. I think our EP team is you know, interested in location, obviously the amount, the location especially as well. They asked about the RV as well, just so they know when they can sort of pull the trigger and put in a device is really from that standpoint in terms of quantification. But if it's a ton, I mean, they come down and look at these pictures with us, so they know, okay, yeah, we got to do this. So definitely.
And you said you bring them back for follow-up. At what point do you bring them back?
Yeah, so usually, well, you know, it all depends on each clinician that refers to us in terms of the timing. Sometimes we see them, we usually don't see them before 3 months. And usually, honestly, it's more like 6 months that we're seeing post-immunotherapy. Depends on kind of what regimen they're on, what, you know, how strong of a regimen they're on. But I would say 6 months, we often see them. Maybe some people wait a year, but 6 months we typically see them, and we look, you know, specifically at those T2 abnormalities and of course the LGE.
Perfect. Thank you very much. That was a great review, and we appreciate you spending your Saturday with us, especially when you're on service.
Yeah, no, my pleasure. Thank you.
I will move on to introducing our next speaker, Dr. Bobby Haidari. Dr. Haidari is an associate professor of medicine and member of the Stevenson Cardiac Imaging Center at the University of Calgary. Dr. Haidari has received research support from the AHA, NIH, and the Lebanon Cardiovascular Institute, and is the author of over 45 original research papers, multiple review articles, and editor of a CMR textbook. He led the creation of the largest stress perfusion CMR program in Canada, the three-dimensional strain HCM registry sub-study, and a prospective randomized clinical trial evaluating the role of high-dose omega-3 fatty acids in attenuation of post-infarct remodeling. He currently serves on the Society of Cardiac MR Clinical Trials Committee, has provided educational lectures for the Canadian Society of CMR, is a gold star reviewer for the JCMR, and is the core lab director for a multi-center study evaluating the role of CMR in MINOCA, as well as pharmaceutical sponsored studies for novel therapies for cardiac amyloidosis and HCM. And it is our pleasure that he is able to talk to us today about stress MRI. Over to you, Dr. Haider.
Well, thank you for that very kind introduction. I really appreciate the invitation. And so today I'm going to give a talk here about stress perfusion MR. I just want to make sure I can share my screen. Are you able to see my screen?
Yes. I think you'll have to switch the modes. We're seeing the presentation.
Swap in place?
Yeah, yes, this is perfect. Yes.
Excellent. Okay. So I have fortunately no financial disclosures. So the outline today, I will go over stress perfusion CMR, how it is conducted, reporting, applications, including in the acute setting and stable chest pain. And then with time permitting, I'll go through a couple of cases that were recently presented at an SCMR webinar. As was very kindly mentioned, over the past 6 years, we've really seen a tremendous growth in stress perfusion at the University of Calgary. And so I'll try to give a few little tips on how we were sort of successful at ramping our volumes. And I think for a lot of the young fellows in the audience, starting new programs or joining programs, there will be more of a need for stress perfusion imaging. So hopefully we'll see more widespread growth across North America. Obviously, cardiovascular disease remains the leading cause of mortality in North America, 1 in every 3 deaths, unfortunately. There's 1 death every 40 seconds. 35 to 40% of those deaths are actually in patients under the age of 75. So this is not just a disease of the elderly. And the costs to our healthcare systems are really, really extraordinary. So over $320 billion per year in the US alone. If you look at the second largest expenditure, cancer, you can see it's about 30% lower. So this does remain a major issue. There are a number of really important advantages to stress perfusion MR over existing modalities that we tend to more commonly use, particularly in North America, a little bit less in Europe, such as stress echocardiography and nuclear perfusion imaging, etc. Stress CMR has very high temporal and spatial resolution, and that allows differentiation of perfusion to the subendocardial to subepicardial myocardial layers, which is why we don't miss balanced ischemia, which can be missed, unfortunately, by nuclear perfusion imaging. There is relative operator independence. We can sort of assign whatever views and planes we wish. It is not limited by adverse body habitus. It does not rely on the necessity, for example, for good acoustic windows like stress echocardiography would. You can evaluate coronary origins in younger patients with not full MRAs, but MRAs targeting the origins of the coronary arteries, which are often much faster and easier to implement in a stress protocol. Within one study, you can get comprehensive assessment of myocardial ischemia, ventricular function, viability. If this is an inpatient or there's some concern about acute injury, as we probably heard a little bit about in the previous talk with T2 imaging, we can even evaluate acute injury and coronary origins, as I mentioned. There's no radiation, there's no iodinated contrast, and stress perfusion MR has demonstrated truly an excellent safety profile. We currently conduct about 1,000 stress MRs per year, and in the past 7 years, we have never had a significant adverse event. So it's very, very safe. and other even larger cohorts have also published those results. It's not, and as I mentioned, it's not limited by attenuation artifacts. So this is a recent image from a review article that I had the pleasure of being part of with Dr. Amit Patel, and we can see here an example of attenuation artifact affecting a SPECT perfusion image. So because there's quite a bit of diaphragmatic attenuation, it's actually affecting the signal intensity on the nuclear perfusion image. So it's kind of debatable whether there's actually a perfusion defect on the SPECT image. In the same patient, when we do an MR, it's readily apparent that there's an inferior perfusion defect, and that actually correlated with a very tight stenosis in the mid RCA. And we typically see this in numerous catheterization laboratories across North America, where unfortunately there are frequent false positives and false negatives with nuclear perfusion imaging. Here's another example from the same review article where I was mentioning the issues with balanced ischemia. And here on the SPECT images for this patient, we can see there does not appear to be any significant perfusion defect, but because we have this beautiful high spatial and temporal resolution, and we can actually look at the perfusion gradient from the subendo to the subepi, we can see that there's a diffuse perfusion defect throughout all of the basal mid and apical slices, suggesting actually either 3 vessel or left main disease. And here, in fact, the patient unfortunately did have left main disease. So what are some disadvantages or limitations to stress MR? Well, metallic devices, although this is becoming more of a relative contraindication with MR compatible devices. Renal dysfunction is always a consideration, although again, recently with the safety profile of group 2 macrocyclic gadolinium agents, we've seen a number of studies and a very large recent meta-analysis reporting that actually the risk of nephrogenic systemic fibrosis from the group 2 GBCAs were exceedingly low. And interestingly, we've seen all of the clinical practice guidelines really shift their policies over the past 10 years. So the American College of Radiology, the European Society of Urogenital Radiology, and the Canadian Association of Radiologists have all revised their recommendation to now approve the use of these agents where necessary in patients with kidney disease or intermittent hemodialysis. I would say severe claustrophobia remains our biggest limitation or contraindication. Sometimes even in larger bore 70 centimeter scanners with sedation, it can be challenging to conduct MRs on patients who have severe claustrophobia. So again, here is an example of a recent case that we did. This is a patient who actually has an MR compatible ICD. This is a 3T. Both of our scanners are 3T systems. And we can see here we have fantastic image quality, and the patient tolerated the study extraordinarily well. This is not projecting well, but this is a case we recently just published in CJC of a patient that needed a stress perfusion MR, and unfortunately had a non-MR compatible device, yet we were able to conduct the study at 3T without any significant issues or really image artifact limitations. So how can stress CMR be conducted? It can be conducted with exercise, although I would say it is extraordinarily challenging for really 2 reasons. One is you need a non-ferromagnetic supine bicycle, and the other is that it induces a great deal of cardiac motion. And so those 2 issues make it really kind of seldom used across North America and Europe. Similarly, dobutamine can be used, but has similar limitations. If you are going to utilize dobutamine in exercise, you often also need an exercise physiologist, which adds extra cost and time and issue. So most centers really concentrate on using perfusion. So with vasodilators, we induce hyperemia or increase in the blood flow to the myocardium through maximal vasodilation of the coronary vasculature. You can get up to 4 to 5-fold, a really powerful increased vasodilation which has been shown to be similar, even sometimes beyond exercise. And this helps us to unmask epicardial coronary artery disease as well as microvascular disease, which we're seeing more and more emerging data on its importance in terms of long-term hazard, not just to women, but also to men. We can evaluate epicardial coronary artery lesions. So you can actually get rest perfusion defects. This has been shown by an eloquent physiologic study by Dr. Andrew Arai from the NIH, particularly if there's a lesion that's greater than 85% in severity. With stress, we can evaluate lesions from 50 to 90%, and we can also employ quantitative techniques. So what are the agents that are commonly employed? So I would say adenosine is probably still the most commonly employed agent. There are some very nice attributes to adenosine that I'll go over. So the typical dose is 140 mics per kg per minute. That's infused approximately 3 to 6 minutes. It's an endogenous vasodilator. It activates A2A receptors, causing vasodilation through cyclic AMP. The activation of A1 receptors, though, can cause AV conduction delay. This is often very transient if it occurs, as well as activation of A2B, A3, A4, which can cause bronchoconstriction. Again, this is also exceedingly rare. The chief real advantage of adenosine is it has an exceedingly short half-life. It's really gone by about 30 seconds. So if you have a quantitative protocol, it's very nice. And also it doesn't require routine reversal. So from that standpoint, it's a very nice agent. I would say dipyridamole is still used in some centers, mainly Europe, but really, unfortunately, is not as useful an agent as adenosine or regadenoson because it just doesn't cause as much hyperemia, but it's cheap. So that's why you see some centers still employing it. Again, here we have the dose, 0.56 milligram per kilograms over 4 minutes. This blocks the cellular uptake of adenosine. It inhibits adenosine deaminase, has a very long half-life, so it requires routine reversal. And oftentimes, and I'm sure as many of you rotate to the cardiologists in the audience that rotate through the spec labs, you'll see that oftentimes patients have significant side effects with dipyridamole. So regadenoson is a newer agent. It has a big advantage in that it's administered as a 400 microgram bolus. So it does not require an infusion pump, and that's administered over 60 seconds. It has selective A2A blockade to reduce potential side effects, although I would say the real world utility of that is probably similar to adenosine. It has very rapid onset and reaches peak hyperemia at about 2 minutes. However, it does have an intermediate half-life of about 30 minutes. So again, if you have quantitative protocols or your patients are developing chest discomfort or side effects, really it does require routine reversal with aminophylline. So what are contraindications to stress perfusion CMR? This often comes up on the board. So if a patient's having an acute coronary syndrome or has any acute instability, severe asthma, reactive airway disease, high degree heart block, bradycardia or hypotension, or any known hypersensitivity to a vasodilator or gadolinium agent. There's lots of literature about caffeine that I won't go into. In general, caffeine does not have as much of a profound effect on vasodilator perfusion imaging as we once believed. In addition to that, you can use a higher dose of adenosine, in particular 210 mics rather than 140 if a patient has ingested some caffeine. But in general, we really like the patient to avoid caffeine 12 to 24 hours prior to any perfusion imaging, and that's also within the SCMR guidelines. As I mentioned previously, all of the vasodilator agents can be reversed with aminophylline. It's a weight-based dosing, which ranges from 50 to 250 milligrams, administered as a bolus over 30 to 60 seconds, and it is a phosphodiesterase enzyme inhibitor. So as I had mentioned previously, the NIH, Dr. Vasu and colleagues did a really elegant study in 15 healthy controls. They actually administered all 3 vasodilator agents on different days. They quantitated myocardial blood flow as well as myocardial perfusion reserve, which is the ratio of peak hyperemia to rest blood flow, and they corrected or adjusted for heart rate. And you can see here, although regadenoson and adenosine demonstrated similar maximum myocardial perfusion reserve, DIPI or dipyridamole, unfortunately, was lower than both regadenoson and adenosine. It's probably why it's really not the agent of choice for your laboratory. So with first pass perfusion imaging with MR, the objective really here is to image or assess the first pass delivery of gadolinium as it's traversing the myocardium through the coronary vasculature, the epicardial and microvasculature following bolus injection. As we know, gadolinium is going to shorten T1 relaxation time and results in an enhanced or increased signal intensity using a T1 weighted sequence. The myocardial regions with lower blood flow will appear hypo-intense by qualitative assessment. However, just note that infarcted myocardium may also appear hypo-intense despite revascularization due to low flow into scar tissue due to destruction of microvasculature. You can also get areas where there's complete obstruction in the coronary artery where there's normal flow because of collateralization. This is one of the real chief advantages of stress perfusion MR. Quantitative evaluation may also be performed essentially by analyzing the dynamic myocardial signal intensity with respect to time. So what we're doing really is with the first pass, we're tracking gadolinium as it's traversing the myocardium by freezing or slowing cardiac motion as much as we can. This is why cardiac motion is one of the chief reasons for artifacts that we do develop, unfortunately. And this is repeated with every sequential heartbeat, and it's conducted for multiple short axis slices, usually 3 short axis slices, as I'll demonstrate, so that we get 16 segment American Heart Association coverage of the left ventricle. There are really 2 important components when you're setting up your perfusion protocols. One is the magnetization preparation for the T1 weighting, and the second is the image readout. So here we see a typical CMR protocol, okay? And so patient is essentially placed in the scanner, localizer images are conducted, a vasodilator agent is administered, and stress perfusion imaging is conducted. As I'll mention, most programs will use a gradient echo or an SSFP readout. This is often followed by short axis functional imaging. Due to time, you want to give some time between stress and rest perfusion to wash out your vasodilator. A second bolus of gadolinium is then administered for rest perfusion imaging, and then this is followed by late gadolinium enhancement imaging. I would say more modern protocols now also involve the use of T1, T2 mapping, even T2 qualitative imaging if there's some concern about acute injury. There can also be time often after rest perfusion imaging to run a short coronary MRA. If this is a younger patient or an adult congenital patient, you're worried about coronary origins. And so this is oftentimes a more modern protocol where we do conduct pre and post contrast mapping imaging. One other short plug that I'll give, maybe I'll give it a little bit later. So with temporal resolution, this is obviously the ability to sample the change in signal intensity during first pass perfusion imaging at the same slice location. Images are required every heartbeat. You really want your TR under 100 milliseconds, ideally. Multiple slices are going to be imaged within one cardiac cycle. So the duration of your imaging readout is important. Time is your enemy a little bit. So the number of slices, this is going to be affected by the number of slices you acquire per one heartbeat, and it's also going to determine your sensitivity to cardiac motion. Spatial resolution is also important, as we discussed. It helps you to distinguish subendocardial ischemia from a gradient within the subendocardium to the subepicardium. You can assess the transmural extent of myocardial ischemia that way. You want to ensure coverage of your 16-segment HA model, and you ideally want to aim for a spatial resolution of under 3 millimeters. So with your image quality, that's also an important component. You want to ensure sufficient contrast between normal and ischemic regions, so bright versus diminished signal intensity, and this is really reliant on your image contrast and your signal to noise ratio. For those of you on 3T platforms, you have tons of SNR, so this is really not an issue. For those of you on 1.5T platforms, you do have to pay some attention to this. And this helps you to derive freedom from artifact. We'll talk a little bit about motion. Motion is an issue. So a lot of the, fortunately, a lot of the new platforms, Siemens and GE, etc., have motion correction built in. So this allows free breathing acquisitions of both stress and rest, which is much easier on your patients and also does improve your image quality. And then, of course, you can also now employ quantitative protocols, which can improve your diagnostic performance. So what are imaging readout options? You can, most programs, I would say, use a gradient echo or a steady state free precession. You know, the advantage of SSFP obviously is you get higher signal, but it comes at the cost of a longer duration in comparison to gradient echo. Echoplanar imaging can also be employed, but is a little bit more historic. The number of phases or heartbeats that you will typically procure is about 60 to 80. However, I would just make a little plug here that if your patient has remarkably compromised LV function, less than, let's say, 30%, you may want to actually increase your phases to 100 or even sometimes 120, depending on the LV function, because redistribution is going to be much slower and you want to ensure adequate duration to actually cover first pass perfusion. We used to actually get the patient to hold their breath and then just breathe as shallow as possible once they could no longer hold their breath. Those are for the old days. Fortunately, many of you young fellows won't have to contend with that. Now with motion correction, the patients can just free breathe through both the stress and rest. So the pre-pulse, obviously we want to manipulate the image contrast to optimize it for imaging as quickly as possible. There are different options. Most programs are going to use a saturation recovery preparation rather than inversion recovery. Inversion recovery will always give you higher dynamic range, but it comes at the cost of time. So that's why most programs are going to use a sat recovery. And you can do this per slice, but again, it comes at the cost of time. So, you know, all of these decisions are always a balance between image quality and time. Artifacts that you should be very aware of, you know, the major one is the dark subendocardial rim, the so-called Gibbs ringing phenomenon. There are various reasons for this, and I'll describe one tip that I would provide a little bit later, but there are different reasons for this. One is cardiac motion. One is partial volume between the myocardium and LV blood pool, where you have a very bright pixel and a very dark pixel at the onset of first pass perfusion. Obviously this will, there are a few tips here on sort of differentiating Gibbs. And you can see my tip here that I wanted to allude to later, which is really rest perfusion. Comparing that to stress, you will see Gibbs on rest perfusion versus a true multivessel or left main perfusion defect. And it will oftentimes precede peak myocardial enhancement. So you'll actually see the Gibbs artifact before gadolinium has even hit the myocardium. You should, however, also be aware of dark banding artifacts due to B0 field inhomogeneity artifacts, and this is often with SSFP readouts. So you want to make sure you shim the heart really, really well. Obviously, wrap or aliasing artifacts is always an issue, and so you always want to do a dry run or an acquisition before you actually administer gadolinium. So strongly recommend for gadolinium administration 2 IV sites. Don't push your gadolinium through the IV that's infusing adenosine or dipyridamole, because that's often where you can induce heart block or other issues. You want to have 2 IV sites. They can be in the same arm, just you want one more proximal to your antecubital fossa, and you always want to make sure that you're aware of your blood pressure cuff. It's terrible when you're running a blood pressure and you're trying to inject gadolinium in the same arm at the same time. Agents with higher relaxivity will require smaller doses. The typical dose of GAD for each stress and rest is 0.05 to 0.1 millimole per kilogram. There is a little bit of equipoise about this currently in the community. So I'll briefly describe the GADACAD study, which was a really instrumental study that got gadolinium actually approved for the first time for stress MR in the US. It's FDA approved, but it's FDA approved at a dose of 0.5 millimole per kg for each stress and rest. Many programs do use a higher dose of 0.075 or 0.1. So just be aware of that. The infusion rate is often 3 to 6 mils per second. Again, this can depend on your LV function. If LV function is lower, you may want to infuse at a lower rate. And it also depends on the size of your intravenous. If you have a patient with very difficult veins, you have a smaller intravenous, then you're going to obviously infuse at a lower rate. This is followed by 25 to 30 ml saline flush, and you're going to use similar parameters for both stress and rest. So this is typically what we'll do is we'll acquire the 4, 3, and 2 chamber images once the localizers have been conducted, and then we'll plan our 3 short axis slices, making sure that we have equidistance between the mid-ventricular slice to the apical and basal slice. We really want to ensure that our basal slice does not protrude into the left ventricular outflow tract, although unfortunately sometimes it does still occur. And of course, we want to try to be as perpendicular as possible to all of the 4, 3, and 2 chamber long axis SSFP views. This allows us to procure a basal, mid, and short axis, and thereby we can apply the 16-segment American Heart Association model. And this also allows us to assess normal or typical coronary artery distributions. Here we see left anterior descending, right coronary artery, and left circumflex. So here we just have an example. I just want to show you typical stress perfusion defect here. I pause the image so we can see that this is within the segments that would be most typical for the left anterior descending artery, anterior septal, anterior, a little bit of anterior lateral involvement. Now, you will hear in a number of talks that a lot of programs are no longer conducting rest perfusion. And I would say if you are at a program where you are extremely comfortable with stress perfusion imaging and or you routinely do quantitation and you have very high quality quantitation, it may be reasonable to get rid of rest perfusion. However, I would just plug or advocate, particularly to the younger fellows, to those fellows maybe starting programs, I would really advocate that you keep rest perfusion imaging at least for the first few years. The reason is it doesn't take much time. It's very easy to conduct. And there will be 5% of cases where you're not certain where could this be a Gibbs artifact or could this be multivessel or left main disease? And that's a terrible situation to be in because that's a really big difference. Either the patient has completely normal perfusion with just an artifact or the patient has left main disease. And you're there equivocating. Rest perfusion really helps you rule out artifacts. So it is something that I, particularly for the younger folks that younger fellows we have that rotate through the Stevenson, I always recommend that they conduct rest perfusion. Now we, unlike nuclear perfusion imaging, of course, we're not comparing stress to rest for reversible perfusion defects. We have the gold standard, which is late enhancement imaging for SCAR. Really what we're using rest perfusion imaging is to rule out artifacts, chiefly Gibbs artifact. You can always, of course, also compare stress to cine SSFP imaging if you're wondering about a regional injury or a hypokinetic segment. And then, of course, as I had alluded to earlier, we are always comparing stress to late gadolinium to look for inducible ischemia. If you have a perfusion defect in an area that's completely infarcted, then the reason you might have a perfusion defect there is destruction of the local microvasculature. that patient is unlikely to benefit from revascularization in that territory if it's been largely infarcted. So we always want to compare to late enhancement imaging for characterization of inducible ischemia. And that's the term you'll see in most of the papers, trials, and post-processing readouts in the guideline. So here's just a quick example. There's an inferior rest perfusion artifact for this patient. But we can see on the late enhancement imaging, there's thinning of this region and there's near transmural late gadolinium enhancement. So this area has largely been infarcted. There's not much benefit to revascularizing this patient's inferior wall, but there is a lateral wall perfusion defect. And we can see here on the late enhancement imaging, there is no lateral late gadolinium enhancement. And so when this patient went to the catheterization laboratory, they actually had a tight OM lesion that underwent percutaneous corneal intervention. I'm also going to make a plug for chest pain, okay, because this is something that's not really described in papers. It's not really described in the SCMR guidelines, but is a major issue in real life when you're conducting your imaging, particularly for those of you starting programs. So many of your patients will develop some degree of chest pain. And I would say if you rush into the scanner and abort the MR as soon as the patient has any chest pain, you will never conduct stress perfusion imaging at your site. So, you know, yes, patients do develop chest pain, but remember, you are monitoring patients closely. You have a pulse oximetry, you have a blood pressure monitor, you do have a VECG, you're communicating back and forth with the patient, and once you actually procure your images, which is fairly fast, you can actually look directly at the stress perfusion imaging. Apart from quantitation, you also have inline imaging. So as you're acquiring the images, you can actually see them on the scanner. So just be a little bit wary of rushing in. You know, there's always a temptation to rush in and abort the study, but that will really, abort your ability to conduct stress perfusion imaging. Obviously, if you're using adenosine, oftentimes you don't even need to provide aminophylline. By the time the stress perfusion study is completed and you go into the scanner to talk to the patient, the symptoms are all gone. If you're using regadenoson, however, oftentimes you will need to administer aminophylline. If your patient's symptoms are persisting or you're concerned about potentially the patient developing acute coronary syndrome, then you may want to administer nitrates and or do a stat 12 lead ECG. But again, this is extraordinarily rare. You must always have an emergent MRI compatible resuscitation policy with a capable physician nearby. And this is something we had to institute at our site when we started doing, when I arrived and we started doing more stress perfusion imaging. 3T versus 1.5T, these images are courtesy of Dr. Jarosh Harold. Hopefully they will play, unfortunately they won't play. So these are essentially 3T images in comparison to 1.5T images. And really all the major point here is that you get higher signal to noise ratio with 3T. So it is a major advantage of 3T systems over 1.5T systems. There's actually data for this. Dr. Cheng and colleagues did demonstrate that there was an improvement in the AUC for the detection of coronary artery disease, but really chiefly for the detection of single vessel disease when you went from a 1.5 to a 3T system. And we see here the AUC went from 0.7 to 0.8 now. It's quite a significant improvement. So it is something just to bear in mind. As I had alluded to earlier, in the old days, we didn't have motion correction. So we can see here there's a lot of breathing motion artifact. The heart is moving up and down as the patient is breathing. But now most scanners will employ a motion correction algorithm. So despite, this is the same case, despite the patient free breathing throughout the study, we can see here that the respiratory motion has been corrected. I will just allude to, although it's rare, that some programs will also do 3D full volumetric coverage. Again, oftentimes there needs to be compromises here. If you're acquiring more data, during the same duration, something is getting compromised, either using more parallel acceleration or you're compromising your signal to noise or temporal resolution. I'm not certain that having a lot more images helps you that much, but certainly if there's a concern about a very small region and you have 3D volumetric coverage, that is an advantage. And we may see this more common in the future once we have better parallel acceleration techniques. I'm just going to talk briefly about quantitation. So quantitation comes in two forms. You can do semi-quantitative protocols. So this was a lot more popular, I would say, maybe 5 to 10 years ago. So here what we're doing is we're actually using the qualitative images, and by contouring the qualitative images and assessing the arterial input function with a dual bolus protocol, we could actually compare the contrast kinetics of stress versus rest and in areas of remote or ischemic myocardium. And this would allow us to use different metrics such as peak contrast enhancement. We could look at the upslope or the upslope integral and compare those ratios and actually provide semi-quantitative numbers. The reason that this really didn't gain a lot of traction is that it's very, very time consuming in terms of post-processing. So as I mentioned, this would typically require a dual bolus technique. If the arterial input function could be well described, you could actually do full quantitation with this technique rather than semi-quantitative techniques. And of course, this would involve a mathematical operation called deconvolution to actually measure the myocardial blood flow. Basically, with the arterial input function, you're describing the contrast kinetics in relation to the actual blood flow through the coronary microvasculature. That, again, for a lot of you young fellows in the audience, that has really largely been displaced by inline quantitative techniques using dual sequences, which are now available, particularly from Siemens, but we're seeing it from the other vendors as well. And this provides pixel-wise inline quantitation. The previous techniques that I had described, which required extensive post-processing techniques, have been validated against fractional flow reserve and PET, invasive fractional flow reserve and PET in small numbers. So it can be done. For those of you that do want to pursue that in your programs, it can be done. It's just it's quite time consuming. However, moreover, what we are seeing now are pixel-wise maps that are actually conducted in line. And this provides us with myocardial blood flow maps, which can be used to measure global or segmental myocardial blood flow. There has been some recent papers sort of evaluating the diagnostic performance of quantitative techniques. This is a very nice study by Dr. Koteka and colleagues conducted in the UK. And we can see here, to be really frank with the audience, the sort of younger folks, sort of in the real world experience of utilizing inline perfusion maps, I wouldn't say that there's been a quantum leap or a significant advancement. In fact, there are some costs to using inline quantitative techniques. One of the costs, for example, is you don't get inline perfusion imaging. So when the stress perfusion images are actually being acquired, particularly if your patient's having chest pain, you actually see nothing until the sequence is completed. So that, for example, is a disadvantage. Oftentimes, another disadvantage is you really need to employ additional reductions of spatial resolutions and increases in parallel acceleration to make sure your temporal resolution is quite high, and that can compromise your image quality a little bit. So, does it help? Yes. Does it majorly help in the real world? I'm to be frank with you, just in my humble opinion, I think the jury is still a little bit out on that. But you can see here that maybe it's questionable. I wouldn't say it's questionable. I would say this patient has quite significant multi-vessel territory perfusion defects. But we see here on the maps, particularly with the numbers, it's very helpful to see that there are significant reductions of myocardial blood flow throughout most of the myocardial segments, suggesting a multivessel or left main disease pattern. And that's exactly what Dr. Koteka and colleagues found, is that really the benefit of quantitation we see here in the green bars was in patients who had more significant multivessel or left main disease from a diagnostic performance standpoint. The prognostic utility has also been evaluated by Dr. Samu and colleagues. And again, here we see when we compare sort of visual grading of the number of segments versus myocardial reserve by quantitative techniques, we're seeing a little bit better separation of the Kaplan-Meier survival curves for adverse cardiovascular outcomes. So really what both studies are suggesting is, particularly in the 2-vessel, 3-vessel disease patients, or the patients that have more of an ischemic burden, we might be underestimating with qualitative imaging. So I'm going to transition here just to briefly describe how useful or the practical applications of stress perfusion imaging. So first of all, can you utilize it in the emergency department for acute chest pain? And it is actually not uncommon that we will actually get a referral straight from the emergency department for a patient, particularly for centers that are using high sensitivity troponin, where the high sensitivity troponin has a borderline elevation. We don't know what's going on with this patient who's presented to the emergency department. And this is where stress perfusion MR can be exceedingly useful, not just because it can assess for myocardial ischemia, but obviously because it can also assess for sequelae of ischemic problems. And it can also assess for other etiologies of chest pain, such as pericarditis or myocarditis or hypertrophic cardiomyopathy, or even infiltrative cardiomyopathies, as you guys were discussing in the last presentation. So here we see an older but very elegant study from Dr. Sven Klein and colleagues, and they actually evaluated 68 patients presenting to the emergency department with suspected unstable angina, and they found remarkably high sensitivity and specificity at 1.5 T for stress perfusion CMR. Likewise, Dr. Inkenasern and colleagues looked at the prognostic utility of the use of stress MR for patients presenting to the emergency department with acute chest pain and low or borderline troponin. And again, we see remarkable separation of the Kaplan-Meier survival curves. The patients with a normal CMR had a fantastic survival. The patients who had a positive CMR had adverse events. And I think one of the best studies that was done is an older study, but really elegant, well-done study by Dr. Vogel, Clausen, and colleagues at the National Institute of Health. And they did a series of 31 patients. It's a small study, but very well done. The patients all received state-of-the-art SPECT, followed by stress perfusion MR for patients presenting with acute chest pain and normal enzymes. This is a bit before the age of high sensitivity troponin, but I'm sure many equivocal high sensitivity troponin patients would have made it into their study. And they actually found that a significant proportion, 30% of patients, had identification of disease by CMR with normal SPECT. And those were typically patients who had diabetes and hypertension. And this is a perfect example. So you see here, patient A on the left has a normal SPECT. Patient B on the right here has a normal SPECT. And we see this CMR, the stress CMR for the patient on the right has a normal CMR study, but the patient on the left had multivessel or left main disease. And this was the phenomenon of balanced ischemia. And this was identified in this really quite significant proportion of their patients. There were also patients where there was identification of a stress-induced apical cardiomyopathy, HCM, myocarditis, pericardial disease. So it really allows you to comprehensively assess patients presenting with acute chest pain and or patients with equivocal enzymes. Dr. Miller and colleagues out of Michigan also conducted a small but fantastic study looking at the cost efficacy. So we see they looked at 110 patients with moderate to high risk. They randomized them to stress MR versus usual care in the ED. We see that the vast majority of patients with stress MR were discharged directly from the ED versus a much smaller proportion of the patients in the standard care arm. Most patients had no event, but there was a 23% reduction in the cost efficacy for stress MR versus standard of care. And now we see that that was about 12 years ago, we've seen costs come down for MR. Now that doesn't seem like a big amount. The median cost reduction was about $588 per patient, but this is almost the same cost reduction that was shown in the ROMACAT trials for cardiac CT in the emergency department that of course was published by Dr. Hoffman and colleagues. So we see potentially very similar cost efficacy. Of course, the vast majority of use of stress perfusion MR is going to be for stable chest pain. And this has been looked at in a number of large meta-analyses showing very high sensitivity and specificity. Don't worry, I'm not going to go over every study, but we see very high sensitivity and overall specificity, really fantastic diagnostic performance. The landmark study was conducted by Greenwood and colleagues called CMARC. They took over 750 patients. All the patients got a factorial design, so they got both a CMR and a SPECT, and then went on to have the gold standard of quantitative coronary angiography. And we see that despite similar specificity for CMR and nuke, there was much higher sensitivity for CMR than nuclear perfusion imaging. This was a really landmark study. They then went on to do CMARC2. So they took 1,200 stable chest pain patients. They randomized them to the NICE guideline, which is essentially a CT first approach versus CMR or SPECT. And look at that, they saw a dramatic reduction in the rates of unnecessary invasive angiography at 1 year for a CMR versus a CT approach. This is very similar to what was also found in the very large scale PROMISE trial. Of course, I want to mention the GATTECAT study. This was really instrumental, particularly in the United States. This was conducted by Dr. Andrew Arai. This was really a remarkable effort. There were two large phase 3 multi-vendor studies. They used different vendors, different field strengths, multiple sites across the world. It was an international study, and they used a reference standard of QCA and really showed just phenomenal diagnostic performance for stress perfusion MR with an AUC of 0.87. And this actually led to the first FDA approval of gadolinium for stress. In my disclosures, I would always say I'm going to discuss the off-label use of gadolinium for MR. I no longer have to do that thanks to the work of Dr. Arai. I want to acknowledge another really instrumental effort that has been published recently by my former mentor and the person who really taught me everything I know about MR, Dr. Raymond Kwong, which is the SPINS registry trial. So again, this was a huge US-based registry of over 2,300 patients who underwent stress perfusion MR across 13 centers. This includes private practice centers, academic centers, regional centers, centers in high population settings, and really conducted high quality evaluations for the prognostic utility of stress perfusion MR. And, you know, Kwong and colleagues really showed really remarkable, robust event prediction. So patients with a negative stress MR, no ischemia or late enhancement, had remarkably good event-free survival at a median of 5.5 years, just amazing, versus those patients who had evidence of disease who had a much worsened or adverse outcome. I briefly want to just also demonstrate before I talk about the other really seminal trial, MR Inform, which is that stress perfusion MR has actually shown remarkably good correlation with invasive FFR. So this is a seminal study done by Watkins and colleagues, and they looked at different invasive FFR parameters and just showed really remarkable agreement between invasive FFR and stress perfusion MR. And we know, of course, now, thanks to the FAME trials, that the use of invasive FFR really can dramatically reduce adverse outcomes for unnecessary intervention, percutaneous coronary intervention, and even potentially coronary bypass grafting. And here, although CT FFR has really shown modest agreement with invasive FFR, we have really fantastic agreement with perfusion MR. And so Dr. Ike Nigel conducted probably one of the most important studies in I would say all of MR, which was the MR Inform study. And so this was a prospective non-inferiority trial comparing stress MR to invasive FFR in almost 1,000 patients who were at moderate to high risk of having coronary artery disease with chest pain, with angina. And really the results are remarkable. So when you look at adverse hard cardiovascular outcomes over 1 year, there's really no difference between MR and invasive FFR, which is very costly and obviously invasive, but is the gold standard. But interestingly, we saw also no difference in angina-free 1-year survival between MR and FFR guidance, but there was a 20% reduction of the use of PCI and CABG. So you're really selecting revascularization and selecting high-risk patients extraordinarily well with stress MR. So it is a really powerful modality. So I know I'm running out of time, so just please bear with me. I'm just quickly going to go over 2 cases. So this is a 41-year-old young lady who had no cardiac history, who presented with stable chest pain symptoms that prompted a cardiac CT at our site in 2014. And we can see she had some moderate disease in the right coronary. The LAD looked fantastic. The images were great. And that there was moderate disease within the left circumflex. At that time, an angiogram was recommended, but the patient was sort of very hesitant to have any sort of invasive workup and was amenable to being on some cardiac medications and really maintained CCS class 1 to 2 status for about 6 years. Unfortunately, her symptoms worsened. This prompted a presentation to the emergency room with unstable angina. She was admitted and referred for invasive cardiac catheterization. And we can see here on invasive cardiac catheterization, she's now developed quite severe mid-RCA disease. And she's also developed really quite severe mid-left circumflex disease. However, there was some equipoise at the time of catheterization about the LAD. And we can see here there's distal collateralization of the LAD to the RCA, which is why this very severe stenosis did not result in an infarct. So what did the angiographer decide? The angiographer decided to put in an IVUS catheter to look at the proximal LAD, really to do the gold standard. And while the IVUS catheter was inserted, the patient developed severe chest pain, ST depression, hypotension. And so a decision was made by the angiographer that there's probably quite severe proximal or ostial LAD disease, and the patient was referred for coronary bypass grafting. Fortunately, the patient actually refused that. She's in fashion. She said, I cannot have a sternotomy scar. I refuse a bypass. And so the surgeons actually referred her for a stress MR. And the stress MR was remarkable. The stress MR showed no LAD territory ischemia. There was quite significant, very, very severe RCA and left circumflex territory ischemia, but really nothing within the LAD. And so the patient went back and actually had a CT, just to 100% convince the surgeons that there was actually no disease, and that the reason that the patient had developed all that ST depression when the IVUS catheter was inserted was because the collateralization from the LAD to the RCA had been temporarily reduced, causing very severe RCA territory ischemia. And so the patient underwent stenting to both the circumflex and RCA, had a fantastic result, and did very well. So I think this is a great example of where MR, particularly in higher risk or complex disease, can be exceedingly powerful. I'm just briefly going to show you one more case, which was a 44-year-old nurse that was referred to our center after developing mild acute decompensated heart failure in the setting of sustained ventricular tachycardia requiring chemical cardioversion with IV propafenone. The patient was referred for a SPECT study. The SPECT study was completely normal, really gorgeous SPECT study. There was a reduced EF, as was shown on the echocardiogram. So what happens? We get this very often. This is a non-ischemic dilated cardiomyopathy suspected. Please rule out something infiltrated. We get this referral often, and it's often after a SPECT study. We change all of those studies to a stress protocol because we are not confident ischemia has been ruled out by a SPECT. And lo and behold, even though this patient came with a very high heart rate, there were multiple stress perfusion abnormalities. And there was even evidence of a small right coronary artery territory infarct. And so this was completely missed by the SPECT imaging. And the patient was actually referred to the cath lab and had evidence of really quite significant severe left main disease and very severe occluded RCA. So the patient ended up undergoing emergent inpatient bypass. So this is just another good example of really the power of stress perfusion CMR. And I apologize for going over, and I thank you for your time and attention.
That was a great review, Dr. Haidari. Thank you very much.
No, my pleasure.
I think Vikram is looking at the chat box.
Sure,
I just had a couple of questions. One is, can you comment about MINOCA and stress testing?
Yes, that's a fantastic question. So we are core labbing for Dr. Harmony Reynolds' MINOCA trial that has now been expanded from women to men. She's presented that at the AHA. So, I think particularly for patients who are presenting with a clear acute coronary syndrome, sending them for a stress perfusion CMR prior to a cardiac catheterization would probably not be conducted in most centers. The areas where we do consider a stress MR and or a CTA actually prior to invasive cardiac catheterization are in particular for younger women where we suspect a spontaneous coronary artery dissection, and we really don't want to be injecting iodinated contrast under high pressure into a coronary artery that might be dissected. So I think that's typically where we might utilize non-invasive imaging prior to invasive imaging. However, for a myriad of patients, particularly if there's some suspicion of hypertrophic cardiomyopathy or sometimes an infiltrative process, we will actually employ a stress perfusion protocol because we do uncover microvascular disease, sometimes quite severe microvascular disease, and also in women. So that's sometimes where in MINOCA, rather than just a non-perfusion MR, we'll actually do a stress perfusion MR.
Awesome. And do you usually do quantification of perfusion mainly in the MINOCA population and even otherwise? Is that your standard protocol, or do you usually do visual?
That's a great question. We're shifting to quantitation. I would say my bias or my humble opinion is I think where quantitation is extremely powerful are in patients where, number one, they may not have coronary artery disease, but they may have some form of a cardiomyopathy, and they may actually have reduced global myocardial perfusion. And this is a real active research area, and this is something that's serially accessible and may even have an impact in the pathophysiology of the disease. One great example is hypertrophic cardiomyopathy. So Dr. Lascauso and colleagues have a phenomenal paper in JACC suggesting that our historical thinking of this as a sarcomeric cardiomyopathy is probably not fully accurate, because there are other cell lines within the heart that are affected that have nothing to do with the sarcomere. And microvascular disease has really been implicated in histopathological studies. And we will see patients, so in our HCM clinic, we have a regional HCM clinic for the southern half of the province. All patients who come in with a new diagnosis of HCM and chest pain get a stress protocol. And here, quantitation can be really powerful because we see quite significant microvascular disease in a lot of these patients. And believe it or not, we'll put these patients on nitrates. And something historically that you say, my goodness, you're putting a HCM patient on a nitrate, but they have phenomenal response and improvement in their quality of life and exercise capacity. And it's because it's the ischemia driving a lot of their symptoms, not necessarily the outflow gradient. So, I think this is really emerging. I think quantitation is a powerful tool. I think, though, we have to just be a little bit careful. I think for experienced centers, quantitation is fantastic, and we're probably using it in more and more of our cases. I think for a lot of the young fellows, though, in the audience who are starting new programs, my strong suggestion is get comfortable with qualitative imaging. It's going to give you your best quality imaging. Think about you keeping rest perfusion. It's 2 or 3 minutes. It's very easy to do. And it really helps to rule out artifacts, because particularly when you're first starting a program and you don't want to miss left main, you don't want to send all these patients to the cath lab saying they have 3-vessel left main and they have normal coronary arteries. Your colleagues will quickly lose faith in your capabilities. So that's just my little humble tip to some of the younger fellows in the audience.
Thank you.
All right. Thank you so much, Dr. Harry. That was a fantastic talk, and those cases were really awesome. I think they kind of highlight some of the key points that you presented in your talk. So thank you for sharing those. We have a few questions in the chat, so if you have time, we would love to go over them.
I just want to make a brief mention that Dr. Chenoy in the chat also endorses a little bit of reservation there about the incremental quality of quantitation. So I'm really thankful and happy to hear him say that. And again, I'm not trying to downplay the value of quantitation. It's extremely valuable, but I think we just have to be a little bit careful. For example, 5 to 10 years ago, when I was finishing my training 5 to 7 years ago, there were many people advocating that we would no longer need to do late gadolinium enhancement imaging. T1 map, native T1 mapping could replace that. I think many of you and maybe some of the experienced people in the audience would agree that we probably still do routinely require late gadolinium enhancement. So it's a little bit of an analogous situation. And sorry, so there was a question about when to utilize dobutamine.
Vikram, you can go ahead.
Yeah, so dobutamine MR is, to be quite honest with you, it is challenging. At the last technologist track talk, I was giving the talk on SCMR, I was giving the talk on perfusion, and there was a very erudite MRI cardiologist from the UK talking about dobutamine. And he basically said the only indication for dobutamine is that you cannot do a vasodilator. So a vasodilator is contraindicated. Maybe the patient has severe asthma or high degree heart block, or has had a reaction, an allergic atopic reaction. And so then dobutamine can be utilized. I would say, dobutamine is not, quote unquote, my pun, for the faint of heart. Oftentimes it's challenging to get to target heart rate. So it's very time consuming. You do often need an exercise physiologist there. You're running a second infusion, and you still want to have IV access for atropine to sort of get the heart rate up. That there's much increased motion of the heart, so you really want your gradient echo or SSFP sequence to be accelerated as much as possible so that it's has a higher temporal resolution. So there's going to be some cost of spatial resolution. So it is challenging to do. It can be done. But I would say most often at our center, if someone is not a candidate, has been referred and not a candidate for a stress MR, we really look more to a dobutamine echo versus a dobutamine MR. However, having said that, we do dobutamine MRs in certain patients, particularly if they're younger and they're not on a beta blocker, and we're pretty confident we can get their heart rate up.
Excellent. Thank you so much for those comments. There's some questions that people send directly to me.
Sure.
So yeah, this first question, interested to know whether you use different sequences for devices when you use the 3T scanners, presumably a shortened protocol. We have never scanned devices on 3T.
Yeah, so now we are routinely doing devices at 3T. So we were fortunate. About 10 years ago, our EP department said all devices going in are MR compatible. However, having said that, sometimes there are legacy devices where the actual ICD device is not 3T compatible, that we will scan. Typically, we'll scan those at 1.5T because there's just so much artifact from the ICD device itself. If the leads are not 3T compatible, though, oftentimes we will still scan those patients at 3T. We will interrogate the device pre and post. We have some support from the electrophysiology labs for that to be done pre and post MR. In general, what we've seen with the SSFP imaging and the perfusion imaging is great quality. We just, as I mentioned, published a case report in CJC. The exception is late enhancement imaging. So the biggest impact that we have seen is the new wideband sequence. It's a Kelman sequence that's now a product sequence from Siemens. And that wideband late enhancement sequence, it's like night and day. So we have, even whether it's 1.5 or 3T. So previously, where we would suffer the most was with late enhancement. We're just not confident about the late enhancement. But I would say in 90+% of patients now with the wideband late enhancement sequence, we get fantastic late enhancement sequence despite having a non-MR compatible device. In terms of safety, again, similar to stress, we have yet to see an issue. We're careful. We consent the patients. We interrogate the devices pre and post. But I think, Dr. Nazarian from Johns Hopkins has done really the seminal work and is the leader on this. And he's demonstrated, because of the high blood flow in the heart, really, there's not much significant, myocardial impact from heating of leads or heating of the can. So, our guidelines have really changed, and then we've seen some endorsement of that from the Canadian Association of Radiologists. I find the American guidelines are often the last to change because they're just a bit more guarded. But I think we're seeing more and more data emerging, and it'll be similar to the gadolinium story that we'll see some liberalization of that in the guidelines.
Sure. Thank you so much. I think this next question you covered in your talk a little bit. Why do we need rest perfusion images? I don't know if you want to comment further, but I think you did go over this pretty comprehensively in your talk.
Yeah, I'll just make the last comment about it, that I think if you go to a lot of, particularly for the young fellows, if you go to a lot of the SCMR talks and you hear from very prominent stress perfusion folks, they'll be advocating to get rid of rest perfusion. And just remember, they are phenomenally experienced individuals, and there are centers that have been historically doing phenomenally high volumes of stress MR. I would say, particularly in a lot of American centers, stress MR is emerging. And, when you're starting, you want to ensure the best diagnostic performance. That's really what we did, which led to a drastic increase in our referrals. So, 2 to 3 minutes, small additional volume of gadolinium, I would really advocate to the younger folks to consider keeping it.
That's a great point there. So next question is, can vasodilation cause ischemia? Hence, would it be suitable for left main stem assessment? Or I think it's probably like, more proximal disease. Would you have hesitation about using vasodilation?
No, I don't. So, again, just remember, everyone always gets quite worried about left main disease. So left main disease is actually a very small proportion of patients who are, we saw that from the ischemia trial, courage trial, Berry 2D trial. It's actually a very small proportion of patients presenting with stable chest pain symptomatology. And I think we've seen in now multiple cohort data sets, even including ischemia, which did have a small MR arm, but in MR Inform and other MR Impact, other very large spins, other very large studies, that the small proportion of left main patients that they had did not suffer adverse events. We probably see left main disease in, I would say, 2 to 4% of our referrals, so very small, maybe 1 in 20 or 1 in 25 patients, and they do very well. Again, after 7 years doing roughly 1,000 patients per year, we have never had an adverse event. So one of the things, however, that we do routinely do is for any patient who has any symptomatology during the stress or patients who have an abnormal stress, we always do a post-stress ECG. So all patients need to have a pre and post ECG. If the MR study is completely normal and the patient had no symptoms, we often don't do a post-stress ECG just for time and patient efficiency. But we do a post-stress ECG. And, only one time because we're keeping track of everything in the database, only once did we see some T-wave inversion in a patient who was asymptomatic, and that patient was subsequently admitted and referred to the cath lab, and the troponins were all negative. So I would say this is very, very safe.
That's really good to know there. I think one last question here is, do you quantify the burden of ischemia by dividing the myocardium to 16 segments together with the endoepicardial perfusion defect, resulting in 32 parts to work out the percentage of ischemia? So I think
that's an excellent question. So yes, we do that qualitatively. Of course, you can quantitatively assess. So we use a 32 model. Some centers just use a 16 segment model. But every large data set, particularly spins and a lot of publications from Raymond Kwong and others, have shown that the degree or the number of myocardial ischemic segments does actually increase the prognostic performance of who is going to have an adverse cardiac event. And we've seen that in other, data sets from cardiac catheterization, cardiac CTA. The more ischemic, the more ischemic heart disease you have, the greater the ischemic burden, the higher your rates of non-fatal MI, stroke, and cardiac death. So yes, it's something very easy to do. We're lucky we have a nice database that's been created by Dr. James White, so we can grade those segments and it actually spits out the numbers there.
Excellent. Thank you so much. I think that's all the questions. There's just a comment. Excellent talk and congratulations. So I want to take the opportunity to thank you for the excellent talk, the cases, and the fantastic discussion. Thank you so much for staying well past the time to kind of answer these questions. I think that was very useful to all the guys who were here.
I'm lucky that this is via Zoom, so the fellows can't throw any of their lunch at me for going a bit long. But I thank you for your time and attention, and I really thank you for the invitation. It was a real pleasure.
Thank you. It was a privilege to have you.
Thank you. Appreciate you joining on this beautiful Saturday and for the excellent talk. Again, all the talks would be recorded for the attendees and will be posted on our website along with the other educational lectures. Go ahead and enjoy the rest of your Saturday. We look forward to seeing you next week. We'll have 2 weeks of lectures on CT scan. So 9 a.m. next weekend. We'll see you all. Thank you very much. Thank you. Thank you again, Bobby. Bye-bye.